So this is the topic that we will cover today in Ops and Gynae. This is the first lecture and we'll complete all the Ops and Gynae in around 4 to 5 lectures with regard to solving of questions in NEET PG. So all those people who have joined on Google Meet, uh, am I visible? Please make a thumbs up. Okay. Thank you very much. Thank you. Okay. So if you have any question, you can type the question because I have stopped the audio. So these are the question. We'll finish abortion, PPH, APS, cervical cerclage, physiological changes in pregnancy, adenomyosis, fibroid, abnormal uterine bleeding, and different signs in pregnancy. So these are the things that we have to finish. So first is the Pisca sex sign. What is a Pisca sex sign? So before understanding Pisca sex sign, we have to understand there are various signs which have been asked. So, for example, if this is the uterus, this is the lateral fornix and vagina, and this part is os. So this is uterus, this is cervical canal which is closed, and this is vagina. Clear? And these are what? These are lateral fornix. These are lateral fornix of vagina. These are lateral fornix of vagina. This you have to understand. These are lateral fornix of the vagina. So now, once you understand this, there are a lot of signs which are related to this. There are a lot of signs which are related to this. What? The first sign that we will read is the softening of the cervix. That is a cervical canal, or we can call it cervix. Softening of the cervix. What it is known as? It is known as Goodell sign. It is known as Goodell sign. So this is cervical canal. So if cervix becomes soft, that is known as Goodell sign. Goodell. That is known as Goodell sign, asked a lot of time. So please remember this. This is Goodell sign. How to remember? Cervix becomes goody. Now then this lower part of the uterus, if this becomes soft, lower part of uterus, if it becomes soft, or this is also known as isthmus. If this area becomes soft, what is this known as? You remember agar. Agar is very soft, so please remember higar. This is known as higar sign. Hegar, higar. So agar, say from agar remember soft, and H remember hysterectomy, where uterus is removed. So when the uterus lower part becomes soft, that is known as higar sign, or when the isthmus becomes soft, that is known as higar. So there are two signs. One is cervix becomes soft. The second is Goodell sign, where the cervix becomes soft, and second is where the isthmus becomes soft. Now third sign are relation to the, we know normally the uterus blood supply is 50 ml per minute, normal blood supply when the lady is not pregnant. But in pregnancy, what is the blood supply? It is around 750 ml per minute. So when in the uterus, there is increased pulsation. In the uterus. There is increased arterial pulsation which can be felt. That is known as, that is why, because there is increased arterial supply, there is increased blood supply to the uterus. So what is this sign known as? Can anybody tell me? What is this sign known as? Yes, this sign is known as Palmer sign. This sign is known as Palmer sign. Why it is Palmer sign? Because earlier they used to keep their palm on the abdomen and they can feel the increased contraction on the uterus because of the increased vascularity, increased uterine arterial supply. So this is known as the Palmer sign. Now, this is lateral fornix of vagina. since the whole blood supply of the reproductive part is increasing, the blood supply of the lateral fornix also increases. So the pulsation can also be felt in the lateral fornix. What is this known as? This is known as Osiander sign. Osiander sign. How to remember DER? Remember third, 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 third from DR. So Osiander sign, increase pulsation. So cervix becomes soft, Goodell sign. Lower uterus isthmus becomes soft, Higar sign. Increase pulsation on the uterus, Palmer sign. Increase lateral fornix pulsation, that is known as Osiander sign. These are the four signs. Then comes the Pisca sex sign. What is Pisca sex sign? Pisca sex sign. Pisca sex sign, please remember, it is related to if this is the uterus. So, embryo can implant on this right side or can get implant on the left side anywhere. For example, if the uterus if the embryo get implant on the left side, this is the left side, this is left side, and this is the right side. So left side will have more growth. Left side will have more growth, more growth. And yes, Dr. Shyam, this increased lateral, these signs are not used nowadays, but this Osiandris, you have to read it for NEET PG. Yes. So, what I was telling, Pisca sign. So, during if lateral implantation, if the embryo is implanted here, if the uterus is implanted here on the left side, so there will be more growth on the left side. First thing. Second, uterus will be softer on the left side. Uterus will be softer on left side. So, what is Pisca sex sign? Pisca sex sign is seen during the lateral implantation of the embryo on the side on which it gets implanted. That side has more growth, that side is more soft. So, that is known as the Pisca sex sign. Now, just also learn one thing, that Jackie Chan loves a blue vagina. This is not reality, but yes. So Jackie se remember and Chan se we have to remember. Jackie se remember Jacquemer, sign. Jacquemer, sign. And Chan se remember or Chadwick sign. Chadwick sign. What is this sign known as? Chadwick sign. Jackmere or Chadwick sign. What happened in this? In this, the vagina, as we are seeing vagina, there is increased vagina bluish coloration. Bluish coloration. Bluish increased vagina bluish coloration due to why am I visible? Oh, sorry. So I will write here. So vaginal bluish discoloration. If someone asks especially anterior vaginal or posterior, although whole vagina becomes bluish because of the venous congestion, so but it is mainly the anterior vaginal or more than the posterior vaginal wall. Okay, so this is called as Jackmere sign or the Chadwick sign. So you have to remember Goodell sign, you have to remember Hagar sign, you have to remember Palmer sign, Osiander sign, Piscasex sign, and Jackmere or Chadwick sign. If you remember these signs, all the questions you will be able to do. Okay, so now this is the question. What does the Osiander signs? Osiander, I have told you from Dar, remember? Dhad, dhad, dhad. So Osiander sign specifically indicate during pregnancy. So I have told you if there is increased pulsation of the increased pulsation in the lateral fornix of the vagina, that is called as uh, sign. So there is increased, answer will be A, increased vascularity in the lateral fornix of the vagina. What does the Goodell sign indicates during the pregnancy? So I've told you Goodell means cervix becomes goody goody. What does I told? Cervix becomes goody goody. Just remember from it, Goodell sign. So soft, it is the softening of the cervix. This is the answer. Okay. So these are the signs which I have already told you. Palmer sign. What is Palmer sign? Palmer sign means increased pulsation in the uterus. Higar sign, isthmus of the uterus or the lower uterine part becomes soft. Goodell sign, cervix becomes goody goody. Osiander sign, there is lateral fornix, increased pulsation. Jackmere or Chadwick sign, when during the lateral implantation, the part where the embryo get implanted becomes more soft and more growth. And Jackmere is bluish discoloration of the anterior vaginal wall due to local vascular congestion. And Pisca's sign is the part in the lateral implantation, the part where embryo get transferred, get implanted, that part has more growth, asymmetrical growth, and it becomes soft. So you just remember this chart. If you remember this chart or what I have told you, you can solve all the questions related to it. Okay. Abortion. Now, abortion questions, there are general tricks to solve this question. You may be knowing a lot of things about abortions, but when it comes to solving question, you will find it difficulty in solving questions. So first I am telling you what are the risk factor for abortion. Risk factor for abortion. So when to say that a lady has abortion, if the weight of the fetus should be more than 500, should be less than 500 grams, should be less than 500 grams, and period of gestation should be less than 20 weeks, then only we will call it abortion. Otherwise, we will not call it abortion. For calling abortion, these two things has to be satisfied. The weight of the fetus should be less than 500 gram, half kg, or it should be less than, period of gestation should be less than 20. So what are the risk factor for abortion? The first important risk factor is increasing maternal age. Okay, as the maternal age, there is increased chances of the abortion. Okay. Second, what is the risk factor? Increasing parity. More the number of times she has become pregnant, that is also lead to the abortion. Third is smoking. Fourth, alcohol. Now there is a debate on the amount of alcohol. Then obesity, diabetes, thyroid disease, and uterine abnormality. Uterine abnormality. So these are the things that you have to know. So risk factor. So whenever they are in the option, you have to think of the abortion. Okay. So in this alcohol, the amount, there is a risk factor in different studies. Therefore, I am not writing what amount of alcohol. They say if you are drinking in moderate amount, WHO say, according to WHO, if you are in more than 14 grams daily, and India say around 28 grams daily. But you don't have to remember these things. Okay. For practical knowledge, remember it, but otherwise, just remember alcohol is a risk factor. So, what is the risk factor for abortion? Now, abortion, whenever there are questions on the, whenever there will be MCQ in abortion, there will be two types of the MCQ. One will be on the spontaneous abortion. That abortion occurs spontaneously, and second will be recurrent abortion. that the question will say that the recurrent abortion is recurrent. So MCQs on recurrent abortions are very tricky. So first I'll tell you how to solve them. First I'll tell you how to solve, and then spontaneous abortion can be in the first trimester and they can be in the second trimester. Okay. So first I'll tell you the trick how to solve in the abortion in the first trimester. So first will spontaneous abortion in first trimester. So they ask you the causes. So always remember A, T, M, T, or in bracket write 16. So what does this A mean? This A means aneuploidy. 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 So these are the causes. What are the causes of the spontaneous abortion in the first trimester? A is for the aneuploidy. Aneuploidy means that normal human chromosome is 46. It can become 45, it can become 44, or it can become 47, or become when the chromosome numbers are increasing or decreasing. That is known as aneuploidy. So the most common cause of spontaneous abortion in first trimester is aneuploidy. It is the aneuploidy. Always remember, it is the aneuploidy. Aneuploidy followed by trisomies. What I am writing? Trisomies. I am not saying trisomy. Trisomies. That means all the trisomies. 13, 18, 21, 16, every trisomy. I am not writing individual. I am writing all trisomies. Then M is for followed by monosomy. Monosomy X. What is this? This is known as Turner syndrome. Turner syndrome. That is monosomy X. Turner syndrome. And which is followed by especially trisomy 16. Especially trisomy 16. Now there can be a lot of questions that they can ask. Simply they can ask which is the first they can ask most common cause of spontaneous abortion in first trimester. Spontaneous abortion first trimester. Your answer will be aneuploidy. Aneuploidy. Then they can ask you which is the single entity or the single disease which is the most common cause of spontaneous abortion in first trimester. Then your answer will be monosomy X, that is Turner syndrome. Because please remember, aneuploidy is not a single disease. They contains a lot of different types of aneuploidy. Similarly, trisomy is not a single disease. They can contain a lot of different types of trisomy. So the third is monosomy. Monosomy is a single disease. So when they ask what is the most common cause of spontaneous, what is the which is the single disease which is the most common cause of first trimester abortion, then the answer will be monosomy X, that is Turner syndrome. Then you will call it monosomy X Turner syndrome. Now, if they ask you which is the trisomy, which is most common trisomy, which is responsible for spontaneous abortion, then you will answer will be trisomy 16. For example, if I say which is the most common trisomy which leads to the first trimester abortion, and I give you four options: trisomy 16, trisomy 18, 21, and 13. So most of the people will write 21. No, answer will be 16. Okay, so again I am repeating, which is the most common cause of abortion, and aneuploidy, followed by trisomies, followed by monosomy X, that is Turner, and followed by trisomy 16. Which is the single disease which causes most common spontaneous abortion? Your answer will be monosomy X. Then they ask which is the most common trisomy, then answer will be trisomy 16. So this we remember. Now, in Turner syndrome, what happened? We have total 45 chromosomes in which we have X, and one X is lost. So we have basically exotype in the sex chromosome. And we see what? Ovarian streaked ovary. We see streaked ovary. Streaked ovary. This has been asked a lot of time. Then there are cardiac problems. Then there are, I am writing this down because a lot of time questions are asked. Cardiac problem. Most common cardiac problem in terminal disease is, can anybody tell me? It is coarctation of aorta. It is coarctation of aorta, followed by bicuspid aortic wall, bicuspid aortic bicuspid aortic wall. This is the most common cardiac problem. So we have streaked ovary, we have cardiac problem. Then we have horseshoe kidney in Turner syndrome. Then more than 75% patient will have recurrent otitis media. Okay. So these things you have to remember. Then very important. Yes, sometimes they ask there is a small fourth metacarpal. Small fourth metacarpal. This has been asked a lot of time in Turner syndrome. Okay. Now what is the physical finding in cases of the Turner syndrome? Physical finding in Turner syndrome will be that you will see webbed neck, webbed neck, and you have low hairline, low placed ears. So this all has been asked as questions. Therefore, I am writing this down. So please remember them here only. Okay. So this was regarding the spontaneous abortion in the first trimester. Okay. Now we will see the causes of. Now we'll see the causes of abortion in the second abortion. So this was the cause of the abortion in first trimester. So there are a lot of, so you have to solve these questions with by keeping in mind these things. Now when coming to the second trimester, the most common problem still remains the chromosomal abnormality. Most common cause will be chromosomal abnormality, which will be followed by the uterine abnormality. Now they ask which is the uterine abnormality, which is the uterine abnormality. So now if I talk of second trimester abortion. So in second trimester abortion, the most common cause will be chromosomal abnormality, followed by the, you have uterine abnormality. And uterine abnormality can be, it can be septate uterus. Septate uterus. If this is the uterus, there can be septa. And this is the most common uterine. So one question was asked, which is the most common uterine abnormality leading to the spontaneous abortion? So answer was, it was septate uterus. Answer was, it was septate uterus. Then it can be bicornuate uterus. It can be bicornuate uterus. Then it can be Asherman syndrome. Asherman syndrome means multiple synecdoche are present. Asherman syndrome means multiple synecdoche are present. Septate uterus, bicornuate uterus, Asherman syndrome. Okay. Then fibroids. Fibroids can also be, that is also known as myoma. They can also be the cause of pregnancy. Then third can be placental causes, for example placental polyp, and then can be maternal causes. Especially you have to remember APLA syndrome. Nowadays APLA syndrome question are being asked in medicine as well as in the obs and gynae. So we'll finish about the separo classification, treatment of EPLA, and what is pathogenesis of EPLA during the recurrent abortion. ठीक. So now this we have understand the second trimester. So we have seen spontaneous abortion, risk factor, what are the spontaneous abortion caused in first trimester, second. Now we'll try to understand whenever there is recurrent abortion, whenever the question is saying about recurrent abortion. First I am writing what are the causes of recurrent. First cause is idiopathic. So most common cause of recurrent abortion is till date is idiopathic because 50% of the people are not able to understand why they are getting recurrent abortion. If you want, I can tell the second is the APLA, anti-phospholipid antibody syndrome. Third is the uterine abnormalities, These are four are septate, bicarbonate, Asherman syndrome. Then you have endocrine cause. Endocrine cause, you have to remember four causes. One is PCOD, other is diabetes, then increased prolactin, that is called as hyperprolactinemia, and thyroid disease. PCOD, diabetes, prolactin, thyroid disease. And then fifth, chromosomal abnormality. I am visible. Is everything visible? Yes. Okay, so chromosomal abnormality. Now these are the causes of recurrent abortion. But even after knowing these causes of recurrent abortion, you will not be able to solve question. So for solving question, I will tell you some important thing that whenever they ask you in cases of recurrent in cases of recurrent abortion, whenever they ask you about the investigation, so you have to follow this order, otherwise you will get confused. Always the first investigation will be TVS. Why TVS? Because transvaginal sonography is a very easy, it is non-invasive. Okay. So, and you get a lot of information, for example, uterine abnormality, any of the abnormality, adnexa abnormality, uterus abnormality, ectopic, everything you can see. So, first investigation will be TVS. If the TVS followed by hysteroscopy, please remember this order. When you will do TVS to hysteroscopy, there are two reasons. If the TVS finding is not satisfactory, that means the person who has done TVS, he say that the TVS finding is not satisfactory, or you get something in the TVS which can be treated through hysteroscopy. Okay? TVS finding which can be treated by hysteroscopy, In these two cases, you will do hysteroscopy. For example, in TVS, you find a polyp. So you can you find an intracavitary or fibroid polyp. Then you can remove that polyp through the hysteroscopy. Or in TVS, you find Asherman syndrome. Then there are multiple synecdoche. Those synecdoche can be cut through a scissors through hysteroscope. So these so so these are these therapeutic findings which you have find through the TVS. So these can be very well treated with the hysteroscope. Or if there is something which is not satisfactory, the person who has done TVS is saying that no, I am not sure about it, then you can also go for the hysteroscopy. But hysteroscopy will never be the first investigation because it is invasive. Patient has to be admitted, patient has to be taken into the OT, patient has to be anesthetized. It is more costly. Whereas all these things are not present in TVS. Therefore, the first investigation will always be a TVS. And which is the last investigation? Let me see, I am visible till what point? Okay, still chromosome 12. So what is the last investigation? Please remember endocrine causes. These are the last in the list, and they are will be always exclusion. When all the things have been finished, then you will tick this option of endocrine. Also, before endocrine causes, there will be chromosomal abnormality. Now, there is a very important chromosomal abnormality. Now, there is a very important point that I am telling you. Initially, now the Williams obstetric books clearly writes that in ages more than 35 years of age, what does the say? In age more than 35 years, the most common cause of spontaneous abortion is chromosomal abnormality. So whenever they say, so you have to pick chromosomal abnormality whenever they say that age is more than 35 years and there is spontaneous abortion. Then only you have to take chromosomal abnormality. Otherwise, there is no use of chromosomal abnormality. Okay. Then you have to take APLA, that is anti-phospholipid antibody syndrome. These are the things. Now, they will always give in the option when one important test, that is serum progesterone. And serum progesterone, please remember, it is, it feels very good. I will take serum progesterone. But please remember, in case of spontaneous abortion, there is no need of doing serum progesterone, although practically lot of doctors do this, because serum progesterone, it has been seen there is of no use in knowing the cause of spontaneous abortion. Secondly, the value of serum progesterone is too, it varies a lot in the pregnancy. Therefore, whenever in the option spontaneous serum progesterone is given, never take this. Second infection. Second infection. Now, I'm going to tell you two important points. Please remember this. Can infection cause abortion? Yes. Infections can cause abortion. I have told you the risk factor of abortions. Please also write that torch infection. They can cause abortion, but infection cannot cause recurrent abortion, because once those infections are treated, they cannot cause recurrent abortion. So never in cases of recurrent abortion take them into the never take infection in the option. If they say that there was an infection but it has not been treated, especially if they mention this, although they will not mention, then you can take it. So there are these two, serum progesterone and infection, they should never be taken in cases of, so this first is the TVS, followed by hysteroscopy, followed by EPLA. You will take chromosomal abnormality when age will be more than 35 years. Or last diagnosis of exclusion, you will take endocrine cross, PCOD, diabetes, prolactin, thyroidism. If you keep this in mind, you can able to solve the recurrent abortion. I will let you solve questions now also. Okay. So now this thing is clear. Now, so please before solving question, mug these things. Remember these things. Now we will understand what are the different kind of abortion. As we have known that when to call anything abortion, if the baby boy is less than 5, baby or male or female is less than 500 grams, that is less than 0.5 kg, and the period of gestation is less than 20 weeks, then we'll call it as a abortion. Now we have understood the causes of abortion. We'll solve MCQ related to it. Now we have to understand what are the different types of the abortion and how to solve the question related to it. Okay. So the abortion types. So abortions can be threatened abortion, threatened abortion. Okay. It can be inevitable abortion. It can be incomplete abortion. It can be complete abortion. And it can be missed abortion. These are the 5 types that you have to understand. Now, how can you solve question? First, I'll tell you a trick. If you understand this trick, you can solve a lot of questions. In MCQ, you will be given two things. One thing will be given that whether internal os is open or closed. Open or closed. Internal os is open or closed. So please remember, just remember this. Whenever anything is open, people come inside. In. Remember this in. So whenever anything is open, people come inside. In. So whenever there will be internal os open, remember where in is written. In is written here and in is written here. So internal os open will be seen in these two. That is inevitable abortion and incomplete abortion. So this is very important. Whenever you see internal os open, you have to choose either of the two. And close, it will be closed in threatened abortion or complete abortion or missed abortion. A lot of your MCQ you will be able to solve from this. Second part. Now there are two things. One is known as period of gestation and second is uterine size. Uterine size. Okay. So what happened? Sometimes period of gestation will be more than the uterine size. Sometimes both of them will be normal. So please remember the cases. There are times when period of gestation will be equal to the uterine size. Actually, what is this concept I am telling you? For example, there is abortion. Abortion has happened at 10th week. But it came to notice at 16th week. So period of gestation is still going on. So period of gestation, what you will say? It will be 16 week. But fetus has grown till 10th week. After death, there was no fetus growth. So uterus growth will not be after uterus will have had grown till 10th week. So what you will say that period of gestation is 16th week, but uterine growth is still 10th week. So period of gestation is more than the uterine. This is the concept of period of gestation and uterine growth. So second point, there can be that period of growth can be more than the uterine size. Can be more than the uterine size. These are the second point. Okay. Now, so how to remember in when period of gestation is equal to the uterine size? So please remember for them to become equal, they have to eat table. They have to eat table. They have to eat table. So eat, say remember eat is coming in threatened. So in threatened abortion and table is coming in inevitable abortion. So in these two abortion, the period of gestation will be equal to uterine size and the rest of the abortion period of gestation will be more than the uterine size. That is in incomplete abortion and in missed abortion. So please remember these 2 points because if you remember these 2 points, you can solve most of the questions. I'll tell you what is actually inevitable abortion, threatened abortion, but please remember that how to solve MCQ just knowing these two things. Internal os open or closed and what is the relation of period of gestation with the uterine size. Please keep this in the mind. If you keep this in mind, now I will go into the next Now we will study missed abortion and spontaneous abortion in detail. And the previous slide, please keep that in mind, because when we will solve question, I'll show you how you can answer question just by knowing those things only. But it is necessary to understand it, so I am telling each and everything in now detail. What is missed abortion? What is threatened abortion? So first write down what is a threatened abortion. Threatened abortion is actually there is a threat to the abortion, that abortion can happen, abortion cannot happen. So there is a threat to the abortion. That so first we will understand what is threatened abortion. Threatened abortion, what will happen? Patient will come with the symptom of vaginal spotting. Vaginal spotting. That is small vaginal bleed. Patient will come to you with a small vaginal bleed. What you will do? You will first do the examination. On examination, you will check two things: internal os and period of gestation with uterine size. So tell me, I have just told you internal os will be open or closed. I have said internal os will be open where in term will be written. So in threatened, in is not written, so it will be, so internal os will be what? Closed. So we will see internal os closed. And period of gestation will be equal to the uterine size. We have just seen in the earlier slide. Now, what will the TVS findings show? TVS finding will show that cardiac activity is present. Cardiac activity is present and everything is okay. It can show you subchorionic small bleed. Subchorionic small bleed. It can show you subchorionic small bleed. So what you will go the treatment? In treatment, you will just state that avoid exertion, avoid exertion, avoid exertion. Nothing else you have to do. This is the threatened abortion. This is the threatened abortion. Okay. Now coming to the complete abortion. What is complete abortion? Okay, what is complete abortion? Patient will give you a symptom that there was vaginal bleeding and pain. Both were present. Both were present. But now absent. So initially the lady will come say, I had a profuse vaginal bleeding, I had a uh, pain, but now the pain is gone and the bleeding is also gone. So this is a characteristic symptoms or history of the complete abortion. So what you will do on examination? So you will do examination. On examination, you will again check two things: internal os, and you will see period of gestation and uterine size relationship. So I have told you internal os open. Open means people will come in. So in has to be written. So there is no incomplete abortion. So internal os will be closed. And period of gestation I have told you will be more than the uterine size. What will you see in TVS? Everything has gone out. Nothing is left inside. So uterus will be empty. So uterus will be empty. So what is the treatment? No treatment. No treatment. But practically, since the lady has lost his child, so what you have to do? Since the lady has lost his child, you have to give counseling. You have to counseling, especially not in our cities, but in bigger cities, in metro city. But any mother can become emotional, so you have to give counseling. Now just compare and contrast it with the incomplete abortion. What is incomplete abortion? Now what is incomplete abortion? What is incomplete abortion? In incomplete abortion, what will be the treatment? What will be the symptom? Symptom will be same: vaginal bleed plus pain. But But the symptom will not be like complete that I was having vaginal pain, I was having vaginal bleeding, but it has subsided. It will be still going on. And incomplete abortion has the highest tendency to go into the shock, to go into the shock. So if they ask you which abortion has the highest tendency to go into the shock, the answer will be incomplete abortion. Okay. So this is the symptom. Now you will do on examination. So you will do two examination, internal os, and you will compare period of gestation with uterine size. So I have told you internal os will be open. So whenever it will be open, people will come inside in. So here in is written, that means internal os will be open. That is just, it is just a trick. So internal os will be open. So in, please remember, internal os was closed incomplete. It is open. What you will see in period of gestation. So period of gestation will be more than the uterine size. What you will see on TVS examination. So in TVS examination, you will see retained product of conception. And what will be the treatment? Suction and evacuation. 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 Have you understand this? Very important. Now I am telling you what is inevitable abortion. Inevitable abortion. Inevitable abortion. Inevitable abortion, the symptom will be same, vaginal bleeding. When you will do what? You will do the internal os. I have told you in is written, that means open, so internal os will be open. Period of gestation will be equal to uterine size. On TVS examination, there can be plus minus cardiac activity. Cardiac activity can be what, because what is inevitable abortion? Inevitable abortion is, that means this is the uterus and the bag and the has come down till os. So product of conception can be felt at the os and the above the os, but not below the os, because it is around. Inevitable means that this abortion is going to happen. Now you cannot, by how you cannot defend it, you cannot prevent miscarriage in this lady. This is going to happen. This is inevitable abortion, as compare and contrast with the threatened abortion. In threatened, generally nothing happens. It is just a threat that abortion can happen, cannot happen. But in inevitable abortion, it is going to happen. So bulging can be felt at the internal os or above the internal os. So this is what it is. So TVS you get nothing. And what is the treatment? Treatment is, you have to let it continue, let it continue, let it continue. But if at any time there is increased bleeding, ladies goes into the shock, then you have to do suction and evacuation. Then you have to do suction and evacuation. So please remember, if the question says in inevitable abortion that bulging has been done, it can be felt at the os, lady is stable, then what you have to do? You have to admit the patient in the labor room, let it pass by its own. But if at any time there is increased bleeding, or if there is the lady's blood pressure start going down, or there is tachycardia, then you have to do suction and evacuation. So these are the four kinds of abortion that I have told you. But now what is left is missed abortion. What is left is missed abortion. Please remember, the question related to missed abortion are very tricky. So I will teach you it in great detail. So what will be the symptom of the missed abortion? Why it is called missed abortion, first of all? For example, if the lady got abortion at 10th week, but there was no symptom and sign at that point of time, and the first bleeding occurs at the 14th week. Then he comes to the gynae clinic. Then he comes to the gynae clinic. So why it is called as a missed abortion? See, if a lady if a lady got abortion at 10th week, abortion happens at 10th week, but the symptoms develop at 14th week. So during this 4 week, the abortion was missed. We were not able to get the we were not able to diagnose the abortion. That's why it is called a missed abortion. So what happened? I will again tell you that period of gestation so is increasing. So period of gestation, if I will ask, it will be 14th week. But uterus has stopped growing after 10th week. So uterus growth will be of 10th week. So what happened in the missed abortion? That period of gestation will be more than the uterine growth. This is the first finding that you see. Okay. Second, what will happen to the internal os? I have told you how to remember it. That if there is in, then internal os is open. So internal os is closed here. Internal os is closed here. Now, so patient will come with the symptom of vaginal bleed plus pain in cases of the missed abortion. In cases of missed abortion. Okay. On examination, what you will find these things. Period of gestation will be more than the uterine size, and internal loss will be close. I have told you what you will see in TVS. TVS you can see cardiac. You will see cardiac activity. You will see cardiac activity. Sorry, cardiac activity will be absent. I'm sorry. So cardiac activity will be absent. Now comes a catch point here. Very important. Please try to understand. Now, there is a missed abortion. There is a missed abortion. You have done TVS. You cannot say that abortion is missed until and unless the gestational sac diameter is more than 25 millimeter and CRL length is more than 7 millimeter. What is CRL length? Crown rump length. Crown rump length. Why? Because there may be chances that this cardiac activity has not come. Because once the crown rump length is 7 millimeter, more than 7 millimeter, there is no possibility that now cardiac activity come. But before crown length lump 7 millimeter, there can be chances that cardiac activity come. Therefore, we have to wait till the crown rump length is more than 7 millimeter because otherwise we may lose a pregnancy where a cardiac activity was coming after some time, was slightly delayed. But just we see all those things and we have given MTP to the. So this criteria has been made that till the time gestational sac diameter is more than 25 millimeter and crown rump length is more than 7 millimeter, we cannot call it as a missed abortion. For example, if you are seeing you have seen a missed abortion and you see crown, so there is a proper guideline that I am telling you from William Obstetrics. So if crown rump length is more than 7 millimeter, for example, they say 10 millimeter, then there is no point. Now the cardiac activity cannot come. So what you will do? You will go for the MTP. You will go for the MTP. You will go for the MTP. But if the crown rump length is 6 or 7 millimeter, then there is high probability of viability. High probability of viability. अब हमारे पास high probability of viability है. So repeat TVS after 7 days. Repeat TVS after 7 days. High probability है non-viability की, that this will be non-viability, but just to be on the safer side, we will repeat. After 7 millimeter crown rump length, there is no possibility of viability, so we will go for MTP. But if it is 6 to 7 millimeter, there is still high possibility probability of non-viability. But we will repeat TVS after 7 days to be on the same side, safe side. If it is less than 6, that is 5 or 4 or 3 millimeter, then there is a high probability of viability that cardiac activity can come, and then but also we will repeat after 7 days, and there is high chances that cardiac activity can come. So please remember that missed abortion is not known called as missed abortion till GSD, gestational sac diameter, is more than 25 millimeter or crown rump length is more than 7 millimeter. And this is the criteria: crown rump length more than 7 millimeter, the baby will not, cardiac activity will not come, go for the MTP. 6 to 7, there is high probability, non-probability that cardiac activity will not come, but you have to repeat a TVS for being on the same side. And if it is less than 5, then it is 5, 4 or 3 millimeter, then there is high probability of viability that cardiac activity will come and you have to do the repeat scan. Okay, when you will solve question. So this was regarding a short tricks to solve the MCQ regarding the itna. So now coming, what is the most common cause of spontaneous first trimester abortion? Spontaneous first trimester abortion. Yes, answer is aneuploidy, because I have told you ATMT. Aneuploidy, trisomies, monosomy X, that is Turner syndrome, and trisomy 16. Okay, so these numbers. Okay, monosomy will be answered if they will ask you individual. Okay. Which is the most common cause of spontaneous first trimester abortion? Monosomy X, trisomy. Again, we use the formula ATMT. Is there aneuploidy? No. Is there trisomy as a whole? No. Is there monosomy? Yes. So answer will be monosomy. Trisomies 2116. They will come after the monosomy. So answer will be monosomy X. Okay. So that's why I was telling you, they ask a very question in a very, know this, a 24-year, am I visible, am I visible, okay, most of the people have gone. So a 24-year-old primary gravida at 15 week comes with a complaint of pain in the lower abdomen, pain for past couple of hours. She also has some vaginal spotting. Vaginal spotting is also there. On physical examination, the uterus is 10 weeks. So what we are seeing? Primary gravida 15 weeks, uterus 10 weeks. So period of gestation is more than the what? Period of gestation is more than the uterine size. This is the first thing that we have come to know. Because we are saying the 20 years primary gravida is 15 weeks. But the uterine size is 15 weeks. Okay, so this is the first. And internal os is closed. What I have told you, open किस में रहता है? Open is incomplete and inevitable. So this may be complete, that may be missed, or this may be threatened abortion. Because in incomplete and inevitable, the internal loss is open. On ultrasound, so now it is closed, so in has been removed. It cannot be incomplete abortion, it cannot be inevitable abortion. Okay, on ultrasound, there is no cardiac activity. So I have told you, no cardiac, in threatened abortion, cardiac activity is present, so it cannot be the answer. So what is the answer? Answer is missed abortion, because cardiac activity is present. And I have also told you that period of gestation is more than the uterine size in cases of the missed abortion, just we have seen. So now see, this is how you have to solve question. You have to keep that thing, internal os thing in mind, period of gestation, uterine size in mind, plus the other thing that I have told you. Okay. Next question. A primary gravida has come at 6 week gestation with dating scan. Okay, dating scan जो होती है, On TVS, there is a uniform gestational sac with yolk sac, fetal pole, with CR length is 7 millimeter, but no cardiac activity. ये क्लासिकल केस किसका है? मिस्ड अबॉर्शन का. अब देखिए यहाँ पे इट इज अ क्लासिकल केस ऑफ मिस्ड अबॉर्शन. सो सीआरएल लेंथ इज 7 millimeter. So I have told you when CRL length is 7 millimeter or 6. So what happens? There is high probability of non-viability. But you have to repeat scan. You have to do a repeat scan after 7 days. So it is a failed pregnancy. No, we cannot call failed pregnancy. High probability of viability, that we will call if CRL length would have been less than 6 millimeter. Progesterone, no. So answer will be high probability of non-viability. Repeat scan after 7 days. This question was asked in AIMS 2017. Okay, so keep this in the mind. Now, a primary gravida has come at 8 week gestation. 8वें week के gestation पे आई with complaint of and on cramping abdomen pain. There is no complaint of this. 8 week पर आई है भाई. Period of gestation is 8 week. Dysuria or increased frequency. On TVS, there is a uniform gestational sac with a yolk sac, fetal pole. CRL is 10 millimeter, but no cardiac. This is a case of missed abortion. This is a case of missed abortion. But now around run length is 10 millimeter and there is no cardiac activity. That means we cannot expect the cardiac activity to come. Now, so what we will do? We will do MTP. So it is a failed pregnancy. It is a failed pregnancy. We will offer MTP. It is a failed pregnancy. We will cardiac MTP. Okay. A female comes to the gynae OPD for preconception counseling. She has a history of 2 second trimester abortion. 2 second, मतलब recurrent. He has a recurrent abortion. This is a case of recurrent abortion. I have told you these questions are very tricky. What investigation will you advise next? Hysteroscopy, endometrial biopsy. So what I have told you? I have told you first is the TVS. If there is some finding that we cannot get from the TVS or there we get something that can be treated, then hysteroscopy. Then followed by EPLA. And in the last we was having endocrine. And if its age is more than 35 years, chromosomal. What we have to never pick? Serum, progesterone, and infections. We don't have to pick. So now, hysteroscopy will be the second. Endometrial biopsy, no. Parental karyotyping if it is more than 35 years. So what will be the answer? TVS. Because we have, it's also a logical thing that first let's see what is there. Okay. So what investigation will you advise next? TVS. Third, in case of recurrent abortion, again there are most common congenital. I have told you it is the septate uterus. There can be septate, bicornuate, Asherman syndrome, and fibroid. These are the anomalies, and out of them, the most common anomaly is the septate uterus. Okay, so most common whenever they ask, it is the septate uterus. Okay, next question. A 40-year-old woman has come to the gynae OPD for consultation. She has 3 consecutive abortion in the past years. Each time in the past, she reached around 6 weeks in pregnancy. But ultrasound has failed to detect any cardiac activity. What is the most likely cause for her recurrent pregnancy loss? Okay. So you have already done the TVS. First thing, you have done the TVS. So no role of TVS. From TVS, nothing has come that you can go for hysteroscopy. And the most important thing is 40 years. I have told you whenever the age is more than 35 years, recurrent, recurrent, recurrent abortion, what you will do? You will go for the what? You will go for the chromosomal abnormality, fetal chromosomal abnormality. Now, in APLA syndrome, please remember recurrent abortions happen. Recurrent abortion happens, but recurrent abortion mainly happened in second trimester. This is also one of the question. So recurrent abortion in APLA occurs in the second trimester. Okay. Now again, a 27-year-old woman has come with a history of two spontaneous abortion, that is recurrent abortion. One at 10 week and other is 15 week. Each time ultrasound show morphologically normal fetus. What is the most likely cause? Now see, endocrine abnormality we have to take at the last. Okay. Now patient has undergone ultrasound and it is normal. That means there is no uterine anatomical abnormality. Infection, I have told you, you don't have to take. To investigate serum progesterone, serum progesterone and infections. You don't have to mark. I have told you. So this now we are left with immunological, that is APLA. So answer will be APLA, that is anti-phospholipid antibody syndrome. Now I am going to tell you something about APLA. What is APLA? APLA is anti-phospholipid antibody syndrome. It is anti-phospholipid antibody syndrome. Anti-phospholipid antibody syndrome. So I have told you in APLA there is recurrent abortion in the second trimester, and there is a criteria which is followed to diagnose APLA, that is called as Separo classification. Separo classification or modified Separo classification, modified in 2006. It is a modified Separo classification. It was modified in 6 otherwise. So what happened in this? It says that if there is a one clinical symptom plus one laboratory finding, if we get any of the one, we get one clinical symptoms and one laboratory finding, then it is an APLA syndrome. So what is the, now coming to the clinical symptoms, what are the clinical symptoms? First is, if there is three, please remember this very, three consecutive abortion at less than 10 weeks of POG, any period of gestation. So if there is three consecutive abortion, why we are taking three? Because normally APLA abortion happens at the second trimester. So if there is three consecutive abortion at less than 10 week of period of gestation. This is the first thing. Second important point. Second important point is that a baby is normal. A baby is normal till 10 week. Till 10 week it is normal. Then there is abortion. Then there is abortion. At less than, then there is abortion. A baby. This is also taken in a clinical sign. Then what is the third? Third is there is a preterm delivery less than 34 weeks. Please remember, every point is important. Preterm delivery less than 34 weeks. Preterm delivery less than 34 weeks due to any of the three reasons. Eclampsia, severe preeclampsia. Please remember, it is not just a preeclampsia. It is severe preeclampsia or placental insufficiency. Placental insufficiency. Okay, so you have to remember these three clinical. You have to remember these three clinical. One clinic out these three clinical, any can be present. First is three consecutive abortion less than 10 week of POG. Why we are taking three? Because generally abortion occurs after 10 week. Then baby was normal till 10 week. Till 10 week. Then there is abortion. This is second. Third, preterm delivery at less than 34 weeks because of eclampsia or severe preeclampsia or placental insufficiency. Okay. What are the laboratory findings? These are there are three laboratory findings. First is anti-cardio lipin antibody. If this is present, anti-beta 2 glycoprotein 1 antibody. I am telling you, only any one of the has to be present. And when lupus anticoagulant antibody is present. So if any of these antibodies is present and if any of this clinical symptom is present, then we say that Separo is positive, and then the patient is classified as Epla syndrome. Patient is classified as Epla syndrome. Okay. So this is very important. Now, if you have classified a lady as Epla syndrome, what treatment you will give? Epla syndrome, what treatment you will give to a lady of this has also been asked. Please, it is low dose aspirin. Low dose aspirin. What is low dose aspirin? That is 81 mg daily. Why you will give aspirin? I will tell you the pathogenesis of Epla. And second, you will start low molecular weight heparin. That is enoxaparin. Enoxaparin. Only enoxaparin is used, although you can also use deltaparin. Okay. So this is the how to diagnose Epla syndrome. One clinical and one this criteria. In a couple with a recurrent pregnancy loss, the following investigation is unwanted. Hysteroscopy, Epla testing, TARCH, thyroid. I have told you TARCH infection is unwanted. I have told you don't have to pick two, TARCH infection and serum progesterone. So answer is TARCH infection. Next, a 28-year-old female has 3 consecutive abortions, all before 10 weeks. All before 10 weeks. Cytogenetic analysis done on the product of conception in the last pregnancy was normal. Okay, so when karyotyping was normal, why you will take karyotyping? She wants to know that what can be done to prevent this from happening again. What is the most appropriate investigation to be provided? Now, I've told you never take serum progesterone. Parental karyotyping already done. Already done. TVS for cervical, and this is done to know the cervical insufficiency. This is done to know the cervical insufficiency. But please remember, in cervical insufficiency, the abortion occurs in the second trimester. It occurs in the second trimester. It occurs in second trimester. So this is also, so what is less? Antiphospholipid, because it is a case of Epla. I have just told you that 3 consecutive abortions before 10 weeks. This is one of the clinical symptoms. And what you have to do now, you have to go for 1 out of 3 lab finding. If any lab finding is positive, then this is a case of Epla. So you have to give low dose aspirin and low molecular weight heparin to this lady. Now, in Epla, what happens is that antibodies are formed against the glycoproteins. If, for example, this is the uterus, so, and this is trophoblast. This is trophoblast, which get implanted in the uterus. So, antibodies attack the trophoblast, so there is a recurrent miscarriage. There is recurrent miscarriages. Also, these antibodies are against platelets. So, there is platelet aggregation. And there can be thrombus formation. And this just to prevent this, the thrombus can be formed in placenta that can lead to preeclampsia, eclampsia. Therefore, why, if you ask why the patient of APLA developed preeclampsia, why the patient of APLA develops preeclampsia? Because we all know that in preeclampsia the basic problem is in the placenta, and in APLA syndrome the antibodies formed against platelet glycoprotein, they can form thrombus. These thrombus can be formed in the placenta, and thus it can develop preeclampsia and eclampsia. Therefore, in the criteria we have also taken into account in severe preeclampsia, eclampsia or placental insufficiency. Third, these antibodies can also these antibody can also are also against the glycoprotein of endothelial cell. Therefore, they can cause vasoconstriction, and they can cause increased BP. The increased BP, thrombus formation, preeclampsia, recurrent miscarriages, these can be seen. Okay, so because increased BP, we can even there is pulmonary artery hypertension is also seen in cases of yeah, in cases of mm, uh, plus. So this is what. So I have told you Saparo classification, what is APLA, and even the pathogenesis and treatment of the APLA. Now coming to the molar pregnancy, a lot of questions is asked regarding to the molar pregnancy. So molar pregnancy is basically of two types. One is complete molar pregnancy and other is partial molar pregnancy. Now first we have to understand what is a complete molar pregnancy. For example, this is the egg. Egg normally had X, but it is a empty egg. It is a empty egg. That means no X chromosome. And a sperm comes to it with X chromosome. Then there is sperm duplication. Then there is sperm duplication. Then there is sperm duplication. So what will happen now? This is an empty X. Sperm has duplicated. So this sperm was having 22 plus X. This was having 22 plus X. So net what will happen? Net will be there 44 X plus X. So net zygote that is formed is diploid. So this is what happened in a complete mole. What happened? A diploid state is formed. Also we can say that both of this chromosome could have been YY. So then Y 44 plus YY would have been formed. So generally there is a single sperm in cases of complete mole. So it is called as monospermic. It is called as monospermic. All these has been questioned. Monospermic. Why? Because a single sperm has come which has divided, and this single sperm has converted into a double. But sometimes two different sperm can also come, so it can also become 44 plus XY. But this is very rare in case of the complete mole. So this is very important. Now what is the question they asked in this? First thing, in complete mole, it is monospermic. Second question they ask, egg is empty. So which get duplication? There is sperm duplication. Second they ask, it is diploid or triploid or monoploid? It is diploid. So all these are question. Egg empty, monospermic, sperm duplication and diploid. Now what will be the clinical feature related? I will tell you. Now in cases of partial, what happened in cases of partial mole? In cases of partial mole, this is the egg, and egg has X. Then sperms come. Now there are two sperm. One has X generally and other has X. So what will happen? There will be it will be 22 plus X. It is 22 plus X. It is 22 plus X. So net will be what? 66 plus X plus X plus X. So it is triploid. It is triploid. Now also we can say that this sperm can be Y. So it can be 66 plus X. One sperm can be Y, other can be X. Yes, this can also be present. 66 plus uh, and this is X and both can be Y, so this is also present. But which is the most common? This is the most common. Similarly, in complete mole, this is the most common. Am I visible? Okay. Now, if I ask you, uh, so this is most common. So in partial mole is triploid. Partial mole is triploid. So now what are the questions that they can frame in this? Question they can frame, yes. I'll change the color. First is that partial mole is triploid. Egg is not empty. And we have two sperm, that is dispermic. It is dispermic. It is dispermic. And this was monospermic. Please remember. And most common is 66 plus X plus. So this is a partial mole. Mole is also known as what? Hydatiform form. It is also known as hydatiform form. Hydatiform form. Please remember. So this is the difference between, very genetic difference between a complete and a partial mole. But now I'll tell you what you will see in the complete mole. Complete mole finding. So you have to see, this is trophoblast. This is trophoblast. This is chorionic villi. Then there is fetus tissue. Then vascularity. We have to see these things in terms of complete mole and in terms of partial mole. So in complete mole we have, why it is called complete mole? Why it is called complete mole? It is called complete mole because there is completely mole, there is no pregnancy. The fetal tissue is absent. Vascularity is absent. Chorionic villi, there is complete degeneration. Complete degeneration. Complete degeneration. Now I am writing here complete degeneration. So chorionic villi, there is complete hydropic degeneration. Hydropic degeneration. So they become grapes like. They become grape like. This has been also asked completely. So what is grape like? In incomplete mole, what we see is a grape like. It is actually the chorionic villi. Now tropoblast. This is the only thing that will have a very high proliferation. So very high proliferation, in high proliferation. And what does tropoblast secrete? It secrete beta SCG. So beta SCG will be very high. It is generally 10 raised to power 5 international unit per liter. So it is of this range 10. So tropoblast, the only thing which is very high proliferating is tropoblast. Now in partial, now coming to the, let me change the color. Now in cases of the partial uh, mole, what will happen? Vascularity, some vascularity. Fetal tissue, some fetal tissue. Chorionic villi, partial degeneration. Partial degeneration. Everything will be partial. And what happened to the tropoblast? Tropoblast, uh, proliferation will be there in the trophoblast, but not as much as in case of the complete. So it will SCG will be less than 10 raised to power 5 international unit per liter. So these are the differences. Okay, so I'm again telling that in complete mole, trophoblast will have very high proliferation. Because of it, beta SCG will be more than 10 raised to power 5. Chorionic villi, complete degeneration, hydropic, so grape-like vesicle will be formed. Fetal tissue absent, vascularity absent. Now coming to the partial mole, the trophoblast will have a partial proliferation, so beta SCG will be less than 10 raised to power 5. Chronic villi, partial degeneration, some fetus tissue present, vascularity, some present. So if you know this much about molar, this was a small recap of which I have given. You can solve a lot of questions related to the molar pregnancy. Okay. True statement about it is of maternal now. Very important points. See, I have just told you that in molar pregnancy, in complete molar pregnancy, what happens? Egg is empty. Egg is empty. So there is no maternal genetic material. No maternal genetic material. Maternal genetic material is not present. No maternal genetic material. Only paternal genetic material is present. Whereas in partial, there is maternal as well as paternal. Both the genetic material is present. This is very important point. Sorry, I forget to tell you. So true statement about complete mole. It is of maternal origin. No, it is of paternal origin. ये paternal origin का होता है. This is of पैटर्नल ओरिजिन. ये पैटर्नल ओरिजिन का होता है. मोस्ट कॉमन कैरियोटाइप इज 40 फॉल. इट इज ट्रिप्लॉइड एंड मोस्ट कॉमन वी नो इट इज 44 प्लस x. ओके, मोस्टली ट्रिप्लॉइड. दिस इज आल्सो फॉल्स. इट इज मोस्टली. ठीक है, ट्रू स्टेटमेंट दे आर आस्किंग. कंप्लीट. मोस्टली ट्रिप्लॉइड. सॉरी, yes, 46 plus x. Yes, 46x plus x is present because it is mainly diploid. They write 40, actually they should write 44 plus x plus x. That means total 46. But some people write total chromosome 46 at one place, then they show XX. So yes, this is true. Mostly triploid, no, it is diploid. It is diploid. Mostly dispermic, no, it is monospermic. Okay, I have just told you monospermic. Dispermic is partial mode. Now, definitive differentiation between a partial mole and complete mole can be done by Alexa. Ploidy status बिल्कुल कर सकते हो, क्योंकि partial mole is diploid, partial mole is diploid and complete mole is diploid. बीटा SCG लेवल पे कर सकते हो भाई. एक है तो कि there is a chance that it is less than 10 raised to power 5 in partial and more than 10 raised to power, but it is not a very good differentiation. So we'll keep it aside now. Histopathology, yes, it is a very good, because in histopathology you can see everything. And then this is what is this P57. So what is this P57? KIP2 staining. What happened was that initially there was time when even histopathological were not able to differentiate complete mole to the partial mole. So this staining came. This was a gene which was seen in which mole? Remember, P in partial mole. So this was seen in partial. This was seen in partial mole. You can appreciate this gene in partial mole, and it was absent in complete. So this was one of the technique, although it is very costly, it was a technique to differentiate. Now actually, if this P57 is seen in partial mole and it is absent in complete mole. Now try to understand a very important thing. In complete mole, genetic material is coming from where? From paternal side. And it is not showing in complete mole. That means this gene is absent in paternal side. It is not expressed in paternally. It is not expressed, because if it would have been expressed paternally, it should also be present in the complete mole. So please remember, question can also be formed that P57 is expressed maternally. Is expressed maternally. It is expressed maternally. This is expressed maternally. It is not expressed paternally. So our answer will be beta SCG because out of them. Okay, this is the answer, beta SCG level. P57 KIP2 gene. Okay. Now, clinical presentation of molar pregnancy. Clinical presentation of molar pregnancy. See, what happens in molar pregnancy? The most common symptom that patient will take is I am having vaginal bleed plus some will say that grape-like vesicles are coming out. Grape-like vesicles are coming out. Grape-like vesicles are coming out. This is the symptom that I am having vaginal bleed and some grapes-like vesicles. Now, we also know that beta SCG is raised. Beta SCG is raised. And whenever there is a raised beta SCG, please remember beta, we will study in physiological changes in pregnancy that beta SCG can behave like TSH. And that's why it can produce increased thyroid and it can produce tremors. It can produce tachycardia. So patient can come to you with tremors, can come to you with tachycardia. Also increased beta SCG can cause excessive nausea and vomiting. So whenever, let me change the color. So whenever in the question it is written excessive nausea and vomiting, please remember it can be a molar pregnancy. Okay, whenever they say tremors or tachycardia, please remember it can be a molar pregnancy. Also, if this is the uterus, there are uterine veins, and these grape-like vesicle can go into this uterine vein and can go in the lungs and can produce what? Can produce pulmonary embolism, can produce pulmonary embolism. Therefore, these patients can show dyspnea. So, if a patient of molar pregnancy is showing dyspnea, what is, although it can be different thing, it can be pneumonia, ARDS, preeclampsia, a lot of things, but in the question, in your NEET, it is always pulmonary embolism. It is always pulmonary embolism. It is always pulmonary embolism. So in pulmonary embolism, in ECG, what is the most common abnormality? Sinus tachycardia. Then you will get S1Q3T3. That is S wave in lead 1, Q wave in lead 3 and T wave in 3. Then you will get what? Right axis uh, deviation. Okay. Then you can get right ventricular hypertrophy. Then you can get T wave inversion, where in lead 2, 3, AVF and from lead V1 to V4. These are the things. And what you will see? Increased D dimer and FDP. Okay, so this is regarding the dyspnea. Now what happened to the on examination? What you will find in examination? On examination, you will find because these pregnancy grow very fast. So what happened? Generally, you will find that fundal height, that is uterine size, is more than period of gestation. Till now, we have read fundal height equal to period of gestational or fundal height less than. But here we are seeing, but it can also be fundal height can also be equal to period of gestation, but fundal height can also be less than period of gestation. But in most of the cases, you will see that fundal height will be greater than period of gestation. And if the question you see fundal height greater than period of gestation, you should always think of the molar pregnancy. You should think of the molar pregnancy. This is on examination. Okay. Then what you will do? You will go for the TVS. TVS in complete mole. What you get? You get snowstorm appearance. Snowstorm appearance. You get snowstorm. Now, very important thing. Since in complete mole, the baby heart is not formed, and in partial also heart is generally not formed. So what happened? There is difficulty in localizing fetal heart. Difficulty in localizing fetal. Please remember, now we have ultrasound, but at the time when there was no ultrasound, these things, vaginal bleed, grape-like vesicle, fetal FH more than fundus height more than period of gestation, and difficulty in localizing fetal heart. These were the only indications. These were the only technique by which we could have think that this patient is suffering from molar pregnancy. Okay, so this is what is molar pregnancy. Now, this is see what is this? This is what is called as snowstorm appearance. Snowstorm appearance, and this is seen in complete mode. This is seen in complete. These are what? These are grape-like vesicles. They can ask you from where they are formed. They are formed from hydropic degeneration of chorionic villi. Hydropic degeneration of chorion. And now this is what is you see in the. You can see amnion, chorion, hole, small vesicle. So this appears like this is a partial mole. This is a partial mole. This is a partial mole, and it gives a picture of missed abortion. It gives a picture of missed abortion. This question has been asked in the neet. Okay, so partial moles gives a picture of missed abortion. Okay. Now, what is the management of the molar pregnancy? How do we manage our molar pregnancy? Is the management different for? So, best management, if you have once you have identified molar pregnancy, identified molar pregnancy, you have to go for SE. What is SE? Suction and evacuation. Suction and evacuation. In one of the question, there was two options. If you are giving with suction in evacuation and second is dilatation and curettage, which you will choose? You will always choose suction and evacuation. Why? Because when you will do the curettage, there is chances that those grape-like vesicle can go into the uterine cavity and can develop pulmonary embolism. So best option is always suction and evacuation. But if in the suction and evacuation is not given, then you will dilatation and then you will choose the dilatation and curettage. Then you will choose dilatation and the curettage. Please remember. This is also you have to go for a baseline beta SCG. Baseline beta SCG. Baseline beta SCG. Why you will do baseline beta SCG? Now I am telling you. Now, anybody who has developed molar pregnancy has a tendency to development of GTN, can develop GTN, gestational trophoblastic neoplasm. Gestational trophoblastic neoplasm. Please remember, if there is a complete molar pregnancy, it has a tendency to develop gestational 15 to 20% chances of development of gestational trophoblastic neoplasm. This has been asked. If there is a partial gestational, partial molar pregnancy, it has a chances of development of 1 to 5% of gestational trophoblastic neoplasm. So please remember this. So we'll do beta SCG. Now beta HCG has to decrease slowly and slowly. But if it becomes stagnant or it becomes plateau or it start increasing, that will give us a hint that, oh, this patient is it's so that its patient is developing GTN. That's why a baseline beta HCG has to be done, and after suction and evacuation you will do what? Beta HCG, regular beta HCG, regular. But just by writing regular, I cannot go out. I have to tell you how regular, because this is very important point that you have to know that how regular. So it is done every week, weekly, till the time 3 beta HCG levels are normal, that is less than 4 international unit per liter, and then per month for 6 months. I am again repeating, it is done weekly till the time 3 beta HCG levels are normal, that is less than 4 international unit per liter, then per month for the 6 months. Because we have to be very vigilant to show, to know, because there is high chances. See, in case of complete, there is 15 to 20% chances that GTN can be there. And in cases of partial, there can be chances of 1 to 15% that GTN can be formed. So we have to be very much uh, vigilant about it. So beta HCG has to be done every week, every week till 3 normal beta HCG level comes, 3 normal. That is less than 4 international unit per liter. Then monthly for 6 months. So this you have to understand. Then monthly for 6. And in the meantime, you have to give 2 advices to the lady. Don't get pregnant. Why? Because if she will get pregnant, beta HCG level will be increased. And when beta HCG level will increase, now it becomes very difficult for us to understand that whether this beta HCG is coming because of the formation of gestational trophoblastic neoplasm or it is because of the pregnancy. Therefore you have to tell, don't get pregnant, and you have to tell her about the contraception. Now there can be asked a question, which is the best contraception? Oral contraceptive pill is the best contraception, and which is avoid, or which is contradicted, that is IUCD. IUCD. IUCD should be avoided because it can lead to ectopic pregnancy and all those things. It can cause uterine rupture also. So this is the very important. So you should be very well when beta HCG, when to do beta HCG, what are the 2 advices you will give to the women, and why you will go for the beta HCG. Okay. Now very important question. Some books write that oxytocin, oxytocin and prostaglandins are to be avoided, are to be avoided. So are they contraindicated? So please remember, oxytocin and prostaglandins are not contraindicated. Before going for suction and evacuation, you should not give oxytocin and prostaglandin. Why? Because if you will give oxytocin and prostaglandin, what happens? There will be a forceful uterine contraction, and the vesicles and the grape-like vesicles can go into the uterine cavity and go into the circulation and can cause pulmonary embolism. But they are not contraindicated. Once suction and evacuation is done, to get the tone, you can now give prostaglandin and oxytocin. Some people gives after suction and evacuation. Some once the when the suction and evacuation is done, after half of the suction and evacuation is done, they ask the anesthetist to start the oxytocin drip or give the prostaglandin PGF2 alpha 0.25 mg intramuscularly. So this is the thing. But they are not contraindicated. But before suction and evacuation, they has to be avoided. Now, second is in these generally these women are of young age. So when to do hysterectomy? When to do hysterectomy? If the age is more than 40 years, or the woman say, I cannot go for the beta HCG level. I cannot go for a routine checkup. She is very poor. Cannot go for the beta HCG, and family is complete. Family is complete. Okay. So if age is more than 40 years, lady cannot go for the beta HCG monitoring, or family is complete, then you can go for the hysterectomy. So you have to remember all those things I have explained, each and everything. Now this is a question. I am visible in the Google Meet. Please, only two doctors are left. Okay. Uh, a 34-year-old pregnant woman present with vaginal bleeding at 11 weeks of gestation. She struggled with excessive nausea vomiting. Why is this? Because of increased beta HCG. Because of increased beta HCG, I have told you. Uh, the fundal height is 22 weeks. See, fundal height is more than the period of gestation. Now, these all things are taking me towards the diagnosis of what? Taking me towards the diagnosis of uh, molar pregnancy. FHS cannot be located. No, this is a confirmed by handheld Doppler. Handheld Doppler 1100 का आता है 1100 का. Okay. What is the most likely diagnosis? So it is a hydatiform mole without any tension. This is a hydatiform. Now next question. A pregnant woman undergoes suction and evacuation for a missed abortion. For a missed abortion. And the product were sent for histopathological examination. 6 weeks later, she comes back with HPE report with feature consistent of molar pregnancy. So I've told you now that missed abortion, that a partial mole can look like a missed abortion. Can look like a missed abortion. This is what happens practically, and this is what has happened in this question. 6 weeks later, she comes with a histopathological report with feature consistent with molar pregnancy. She does not complain of any bleeding at present. Her pelvic examination is normal. What is the most appropriate investigation at the present? What will you do? You will go for the serum beta HCG. I have just told you, because you have to do the monitoring of serum beta HCG per week till 3 reading comes normal, that is 4 international unit per liter, then every month till the 6 months. So you will go for the serum beta HCG. There is no need for blood doping. Maternal karyotype is of no need, because he has already got for histopathological examination and pelvic ultrasound of no use, because you have histopathological prove that this patient is having mole. And mainly, which mole it is? It is mainly a partial mole. It is mainly a partial mole, because it doesn't like missed abortion. Okay. A 34-year pregnant woman present with a vaginal bleeding at 12 week of gestation. She is troubled with excessive nausea and vomiting. See again, the fundal height is 12 weeks, more than the period of gestation. Ultrasound shows no strong appearance. That means it is a complete mole. It is a complete mole. What is the best management is what? Suction evacuation. I have just told you. Suction and evacuation. Now, see this. After suction and evacuation for complete molar pregnancy, this woman is counseled for all. We have done the suction movement. Weekly beta HCG followed up is required. Bilkul, we will do beta HCG. The chances of recurrence is 2%. So I have told you that in molar, if a lady has a molar pregnancy, if has a single molar pregnancy, the chances of next molar pregnancy is 2%. If has a history of 2 molar pregnancy, then chances of next molar pregnancy is 20%. So chances of recurrence is about 2%. Is this true? So this is a single pregnancy. The chances of recurrence is 2%. Yes, this is also true. The chances of recurrence is about 20%. No, this would have been chances if there was history of 2 previous molar pregnancies. The risk of GTN is 15 to 20%. So I have told you, in complete mole, the chances of GTN is around 15 to 20%, and in partial mole, the chances of GTN is 1 to 5%. So this is also true. So our answer is All except this. The chances of recurrence is about 20%. This would have been answered if there would be history of two molar pregnancy. Okay. Next question. A 34-year-old pregnant woman present with vaginal bleeding at 12 weeks. She struggled with excessive nausea and vomiting. The fundal height correspond to twin. Ultrasound shows snowstorm appearance and bilateral enlarged cystic ovary. What is the best management? One thing I forgot to tell you, that we have a very large beta C. This is, we know, this is a complete mole. This is a complete mole. So there is enlarged beta ECG, and this ECG can stimulate ovary, and there can be bilateral theca lutein cyst. Bilateral theca lutein cyst. Bilateral theca lutein cyst. Now, what is the management of this bilateral? Please remember, when you do suction and evacuation, generally within 4 months, this theca lutein cyst disappears. So we don't have to do anything extra for this until and unless it is twisted. If this theca lutein cyst is twisted, if it is twisted, then what you have to do? Then you have to go laparoscopically or through laparotomy. You have to do untwisting. Untwisting. You don't, bilateral salpingo-oophorectomy is not done. So you have to do untwisting. So remember, if there is a bilateral theca lutein cyst after suction and evacuation, it goes within 4 months. But if it is present, we never do bilateral salpingo-oophorectomy. If there is twisting, then we will untwist it. Okay. So this is the, what is the best management. There is, she is double accessing the fundal itna shows nostril and bilateral enlarged cystic ovary. So what is this? This is actually a bilateral theca lutein cyst. Suction evacuation, yes. Ovarian cystectomy, no. Hysterectomy, no. No. BSO is never done. So answer will be suction and evacuation. Now next question, a 34-year-old pregnant woman present to the emergency at 12 weeks with acute severe abdomen pain associated with mild vaginal bleeding. On per abdominal finding shows tense and tender abdomen. Ultrasound shows snowstorm appearance, that means complete mole. And bilateral enlarged cystic ovaries with findings suggestive of right-sided ovarian torsion. See, now there is a torsion. Now you have to do suction evacuation, plus you have to do the untwisting. So what you will do? You will do the suction evacuation and untwisting. No need of chemotherapy, no suction evacuation alone, because here twisting is present. Because twisting is present. Agar if there would have been absent twisting, then you could have done hysterectomy. No. Okay, so this is a very good question. Now, this question, you have to understand what are the is the role of chemotherapy when you will start chemotherapy in the patient of. Now, there were there were 9 indications earlier. What their indication was? If the age is more than 40 years, if the age is more than 40 years, if there is bilateral theca lutein cyst of 6 centimeter, if there is beta SCG baseline more than 10 raised to power 5, if there is abdominal bleeding, vaginal bleeding, beta SCG of more than there is plateau or increasing trend of beta SCG, or beta SCG more than 20,000 at 4 weeks, or if there is a biopsy proven specimen of cancer, or if there is a metastasis. These were the 9 indication for chemotherapy. But now there is something has changed. So earlier, in cases of during when there was follow up of what? Follow up of molar pregnancy. When there was follow up of molar pregnancy. So in follow up of molar pregnancy, there was, we used to give chemotherapy if there were in these 9 indications. In these 9 indications. What were these 9 indications? First age more than 40 years. B. Bilateral theca lutein cyst. I have told you that bilateral theca lutein cysts are found more than 6 centimeter. Then baseline beta SCG more than 10 raised to power 5 international unit per liter. Then fourth was, now I will write with a different marker. Why I will tell you. Now fourth was abdominal bleeding, continuous vaginal bleeding. Sixth, beta SCG plateaus or beta SCG increase, because when we do beta SCG level, it has to come down. But if it plateaus or if it increases, there is high chances that it has become cancer. Then 7, beta SCG more than 20K at 4 weeks. And 8, biopsy proven cancer, carcinoma or distant metastasis. Because all these nine parameters used to tell about increased risk of gestational trophoblastic neoplasm. So we used to give chemotherapy to all these 9 people. But it was seen in studies that giving this too much of chemotherapy was futile, was not changing the outcome, and also most of these people were not having gestational trophoblastic neoplasm. So further a lot of studies were done, and they have seen that these initial 3, that is age A, B and C, these may increase the risk factor for the gestational trophoblastic neoplasm, but they are now not a indication for chemotherapy. They are not an indication for chemotherapy. So if they ask you what are the risk factors of gestational trophoblastic neoplasm, you will tell all these 9. But when you have to give chemotherapy, then just these 6 are indication for chemotherapy. Please remember, I am again telling, these all 9 are risk factor for development of gestational trophoblastic neoplasm. But these all 9 are not indication for chemotherapy. Indication for chemotherapy are just these 6. So having said this, if you know this, this is the question. Women with complete molar pregnancy it has risk of developing gestational trophoblastic neoplasm. All of the following increases the risk. Age more than 40, yes. Beta CG more than 1 lakh, yes. Bilateral, yes, not the future of thyrotoxicity. This is the answer. So please remember, these 3 are risk factor, but they are not indication for chemotherapy. So the answer to this question is C. So indication for chemotherapy, I have already told the 6 indication for chemotherapy. These are abdominal bleeding, continuous vaginal bleeding, beta CG plateaus or increases, beta CG more than 20,000 at 4 weeks, biopsy proven carcinoma and distant metastasis. Now, so we have finished the molar pregnancy. Now we'll come to the cervical cerclage. What is cervical cerclage? What is cervical cerclage? This is the uterus, lateral fornix, vagina, and this is the cervical canal. So we put a stitch here at the cervical canal so that the fetus does not abort. Fetus does not come down. This is a general way to understand what is the cervical cerclage, or in simple terms, we also call it cervical stitch. Cervical stitch. So there is a stitch at the cervical canal done most commonly at 12 to 14 weeks. 12 to 14 weeks to prevent the abortion of the in case of cervical insufficiency, when cervical canal is not competent enough to prevent the abortion, miscarriage or preterm labor, we do this. Now there is a lot when you study cervical collage, it looks very easy. But first I'm telling you when to think, when to think that you have to offer cervical cerclage. Either you say cervical cerclage or cervical stage to a woman. The woman should have a bad obstetric history. Women should have a bad obstetric history. This is very important. Bad obstetric history. Bad obstetric history means women should have recurrent abortions generally in second trimester. Recurrent abortion generally in second trimester. Recurrent abortion generally in second trimester. Second, the woman could have recurrent preterm delivery. Recurrent preterm delivery. Or he say history of passage of baby through uterus. He will say that I was sitting down, I was passing stool, and I also passed the baby. So if these things are present, then you will say that this lady has a bad obstetric history when we relate it to the cervical. Then you will think of cervical circulage, but you will not start giving cervical circulage to this lady. There are proper indication of giving cervical. So why cervical circulage giving? Cervical circulage, why we give? To prevent recurrent abortion, to prevent recurrent preterm delivery, and so basically these are two: recurrent abortion, recurrent preterm delivery. Now, please remember these things because I will again come that it is the cervical cerclage is given to prevent recurrent abortion and recurrent preterm delivery. I will again come to this thing. It is very important. So now, what are the actual indications that you should know and while solving MCQ? So the first thing is history, history guided, history guided cervical circulage. History guided cervical circulage. Whenever there is three or more than three abortion in a lady, whenever there is three or more than three abortion in a lady, plus there is cervical insufficiency, then you will give this lady what? You will give cervical circulage. You will give cervical circulage. Now you will ask, and this cervical circulage will be known as history, history guided cervical circulage. Now what is cervical insufficiency? Cervical insufficiency is diagnosed in pregnancy in a different way and a non-pregnant woman in a different. In a non-pregnant woman, if Hagar dilator, you should know which number? 8 number. Hagar dilator can pass through Os easily. That means there is cervical insufficiency. So if I'm changing the color, if Hagar dilator can pass through this easily, then in a non-pregnant woman we will say that this is cervical insufficiency. When to say in pregnant, when to say cervical insufficiency in pregnant women? If TVS show that cervical length is less than 25 millimeter or funneling of internal os, funneling of internal os. If these things, so first indication is history guided cervical circulage. There are two indications when there are three or more abortion plus there is cervical insufficiency. So you will give cervical circulage to this lady. Now they can ask, if you are giving history guided cervical circulage, what is the best time? There are two questions. What is the best time and maximum up to when you can? Maximum you can give it till 24 week. Maximum you can give it till 24 week. Maximum you can give it till 24 week. and the best time is 12 to 24 week. 12 to 24 week. Best time is 12 to 24 week. Now I have told you that uh, cervical cerclage is given to prevent recurrent abortion and recurrent preterm delivery. Now understand why you should avoid giving about cervical cerclage after 24 week. The reason is being because after 24 week, the main purpose of giving cervical cerclage is to prevent recurrent abortion and recurrent preterm delivery. But when you give after 24 week, it can cause rupture of the membrane, it can cause preterm delivery, it can even cause abortion. Therefore, to prevent preterm delivery, rupture of membrane, it should be given before 24 weeks. After 24 weeks, 4 weeks, cervical cerclage is not indicated. So whenever in the question they tell you always never mark those option which is after 24 weeks. Okay. So this was history guided cervical cerclage. Second indication of cervical cerclage is uh, ultrasound guided. Second is ultrasound guided cervical cerclage. Ultrasound guided cervical cerclage. What is ultrasound guided cervical cerclage? If there is a one or two if there is history of one or two pregnancy loss, pregnancy loss plus there is cervical insufficiency. I have told you what is. Then what you will do? Will you give uh, cervical cerclage to this lady, and this lady comes to you? So what you will do? You will do TVS serial monitoring. You will do TVS serial monitoring, and at the time whenever the cervical length is less than 25 millimeter, you will go for cervical stitch. You will go for the cervical stitch. So now there is a catch. If a lady comes to you at 18th week and its cervical length is, he has a history of one or two pregnancy loss and the cervical length is 29 millimeter, will you give? No, you will not give because there is no, the cervical length is not less than 25 millimeter. Now this lady at 23 week come and the cervical length is 24 millimeter. Yes. So when at 18 weeks cervical length was 29 millimeter and there was history of one or two pregnancy loss, there was history of cervical insufficiency. So you had what you have done. You have serial monitoring was done by you. And when at 23 weeks cervical length was 24 millimeter, you have given the cervical stitch. Please remember, don't go by the what happening in the practical, because in actual practice if it comes at the 18 week they will give a cervical stitch, but not according to the guideline. It is not. You have to do the serial monitoring, and when the cervical length is less than 25 millimeter, then now if the same lady comes at 29 week and cervical length is 24 millimeter, will you give cervical stitch? No, because why? Because now the period of gestation is 29 week. Your cervical stitch will can lead to premature rupture of membrane and preterm labor. So this you have to understand. Then there is third very important thing. If a lady comes to you and you see that there is a bag is bulging and there is bag is bulging and uh, cervix is dilated. So here there is no need of previous pregnancy loss. Here you will give cervical cerclage to this lady, and that is known as rescue cervical cerclage. This is very important. This is called as a rescue cervical cerclage. Please remember this one. So ultrasound guided, X-ray guided, and this is the. What are the side effects? Side effects I have told you what are the side effects. It can cause bleeding, it can cause infections, it can cause preterm labor, and premature rupture of the membrane. So this you have to understand. Okay. This is the question. A eight-year-old pregnant woman comes to the gynae clinic at 12 week of gestation. At which week? 12 week for her visit. In the last pregnancy, she had history of spontaneous expulsion of fetus in the 6th month. There is spontaneous expulsion of fetus. There was no pain or vaginal bleeding. Ultrasound confirmed a single uterine pregnancy. How can you confirm the diagnosis of cervical insufficiency? Now I have told you there is history guided. So in history guided there should be at least 3 pregnancy lots. So you cannot go for history guided. In TVS there can be 1 or 2. So TVS guided cervical stitch. He is coming in TVS guided cervical stitch. So what you have to do in this, you have to go for the serial monitoring. Serial monitoring till the cervical length is less than 25 millimeter. Here the cervical length is, they are not telling about the, they are asking you how can you confirm the diagnosis. So confirmation कैसे करेंगे? Regular TVS cervical length monitoring, regular TVS cervical length monitoring. So he is coming in this category, second category. So we will do TVS serial monitoring, and when the cervical length will be less than 25 millimeter, we will go for a cervical stitch. The answer is C. Okay. A gravida 3 female with history of 2 prior second abortion. 2 abortions have been done. Associated with history of painless cervical dilatation. Comes to you with level 2 ultrasound, show funneling of internal lobes and closed cervical length of 12-15 millimeter. So that is means there are, I have again told you, if there are 3, then you have to go for the history guided. Now there are 2 laws. So you have to go by the ultrasound guided, where you do what? You do serial ultrasound, or when the and when the cervical length is less than 25 millimeter. But now, is there any need of serial TVS? No, because you are showing the cervical length is 15 millimeter. So right now you have to give the cervical stitch. So you will give the cervical stitch. So now answer will be apply McDonald stitch. So right now you have to give the cervical stitch. You have to go for the serial. Just 1 minute. Dr. Danish, see, we have to go for the serial monitoring in case of ultrasound guided. In that cases where the cervical length is more than 25 millimeter. If the cervical length is less than 25 millimeter, you don't need to go for the serial monitoring. Why you will go for serial monitoring? You at that time you will give the cervical stitch. So answer will be C. McDonald's. Okay, now what are the different ways to give cervical stitch? This you have to understand. Cervical stitch. First is you can go for the McDonald stitch. McDonald stitch. Okay. And second is Shirodkar stitch. Okay. It is done through non-absorbent suture like proline, and Shirodkar stitch. It is generally given through Marceline. Now, administer progesterone. See, very important point. Progesterone, if there is a cervical, you see a cervical insufficiency in a primary gravida, then you can give progesterone, because now progesterone has been approved to prevent premature preterm labor in primary gravidas. P say primary gravida, P for progesterone. In primary gravida, you can give progesterone for prevention of preterm labor. So, but here it is not. So it is not a primary gravida. So this is not Apply fourth wheel. Stage of fourth wheel operation is done for uterine prolapse. It is done for uterine prolapse. It is done for uterine prolapse. So this is not the option. This is weekly progesterone injection. No, I just told you. The answer will be apply McDonald stitch or apply Shirodkar stitch. This will be the answer. Now, gravida, 3 female, 3 gravida. With history of 2 prior abortions associated with history of painless cervical dilatation comes to you at 20 weeks with complaint of profuse thin white vaginal discharge. The uterus is relaxed. On per scap, the cervix is short and dilated and intact. Ultrasound shows a healthy life course. So I have told you cervix is short, dilated, intact membrane. Okay. So what you will vaginal discharge is there, complaint of profuse vaginal discharge, there is history of cervical dilatation. So here you will, what you will do, you will do immediate cerclage, that is called as a rescue cerclage. You will go for the rescue cerclage. Okay, in second trimester you cannot go for the emergency LSCS. Expectant management, why you will go for expectant? There is painless cervical dilatation is there. They, the baby can come down. It has dilated to 3 centimeter with intact membrane. So why you will not do expectant management? Progesterone is, there is no role. It is not a primary gravida. So what you will do? Immediate. This is known as rescue cerclage. So you will go for the rescue cerclage. Okay, this is also previous PYQ. Now this question. This was asked in AIMS examination. A 5-year-old, sorry, 5 is not. इतना old primary comes for a routine antenatal checkup at 20 weeks. The level 2 ultrasound shows single healthy live fetus. ठीक है? It is a primary gravida. He is a primary gravida. He is a primary gravida. What is the next best step? So I have just told you in primary gravida, progesterone. So progesterone therapy can be given. Immediate cervical cerclage of routine follow of cervical. So this. So once you understand, whenever you see a question, you should try to know is the history guided. If the abortion is 3 or more, history guided. If abortion is 1 or 2, it is ultrasound guided, where you have to do serial monitoring. But if the length is less than 25, there and then apply cervical stitch. Uh, if it is there is cervical dilatation, there is membrane seen, you patient can develop anytime miscarriage, then you have to do the rescue cervical cerclage. And P for progesterone, P for primary gravida. If there is a primary gravida, to prevent preterm, progesterone therapy can be given. Okay. Now coming to the placenta, previa and abruption. Now we will be starting with the APH, abruptio placenta. Now, so what first we have to understand what is placenta previa, what is placenta abruptia. So if this is your uterus, what happened in placenta previa? This is the uterine, lower uterine segment. This is the lower uterine segment. If the placenta get implanted here in this area, that is known as placenta previa. That means, what is placenta previa? Placenta previa is abnormal implantation of normal placenta. Please remember, placenta is normal. I'll change the color. It is abnormal implantation of normal placenta. So why it is called abnormal? Because it get implanted at lower uterine segment. Lower uterine segment. It get implanted at the lower uterine segment. This is very important. So abnormal implantation of the lower plus of the normal placenta, that is called as the placenta previa. Now what happened to the placenta abruptia? In placenta abruptia, what happened is a normal implantation of abnormal placenta, of abnormal placenta, normal implantation of, so placenta may be implanted here, but the placenta itself is abnormal. And when the placenta is itself abnormal, what it can cause premature. So prematurely, it is abnormal placenta, it will not go till the term. Prematurely, it will be peeled off, it, uh, it will be removed from the uterus. So there can be premature rupture of placenta. So in placenta previa, abnormal implantation of normal abnormal implantation means lower uterine segment, and this is placenta abruptia means normal implantation of abnormal. Now we have to understand what are the types of placenta previa. Okay. So if you see, this is the os, you are seeing from above, you are seeing os from the above. Okay. So, and this is the area 2 centimeter around the os. So any placenta, what is placenta previa? Placenta previa is abnormal. Placenta previa is abnormal implantation of a normal placenta. So any placenta which get implanted around 2 centimeter of the internal os, that is called as placenta previa. If the for example placenta is implanted here, that means it is around 2 centimeter of the internal os, but it is not touching, that is called as a grade 1 placenta previa. So grade 1 placenta previa is that it is within 2 centimeter of the internal os, but it is not touching the internal os. Then if the placenta is like this, that is called as grade 2 or called as a marginal placenta previa, marginal placenta previa, where the only it is touching the just margin of the internal os. Okay. In the first, it was around the 2 centimeter of the os, but not touching. In second, grade 2, it is marginal placenta previa because it is just touching the margin of the internal os. Then grade 3, it is known as partial placenta previa, partial placenta previa, where it is covering more than 50%, where I'll change the color, where the placenta is covering more than 50% of the os, more than 50% of the os. And then comes the grade 4 placenta previa, grade 4 placenta previa, that means also known as a complete placenta previa, very dangerous, where it is completely covering the internal os. It is completely covering the internal os. Grade 1 and 2 are known as minor placenta previa, and grade 2 and 3 are known as major placenta previa. Also in ultrasound, a lot of time radiologists write low-lying placenta, low-lying placenta. So low-lying placenta means that is minor placenta previa, that is grade 1 or grade 2. Okay, so these are the basic things. This should be very much clear to you. Okay. Then abruptio placenta. What is abruptio placenta? Abruptio placenta, I have told you, it is the normal implantation of abnormal placenta. For example, a placenta is abnormal, it is implanted here. So now bleeding can be just behind the placenta, or bleeding can be here also. Bleeding can trickle down here. So if the bleeding is just behind the placenta, that is known as concealed placenta, abruptio placenta. But this is very dangerous because there will be bleeding, but in vagina we will not see any bleeding coming out, but on monitor you will see blood pressure is falling, heart rate is increasing. So this is concealed abruptio placenta. Whereas this is called as a revealed, this is the revealed variety of abruptio placenta. Here the bleeding will be visible, so you can correlate with the monitor that yes, blood pressure is falling, heart rate is increasing, is bleeding. But in abruptio placenta, the amount of blood loss will not correlate with the hypotension patient is having. This is the placenta previa. Okay. Now we should know what are the risk factors. So first we'll go for the risk factor of placenta previa. Okay. What are the risk factor for the placenta previa? Increasing maternal age. Increasing maternal age. Increasing paternity. And smoking. These are the risk factor for placenta previa. A very important point, these are also the risk factor for the abruptio placenta. Increasing maternal age, increasing paternity, increasing smoking. These are also risk factor for placental abruption. Now, coming to the risk factor here, multiple gestation. Multiple gestation means twins pregnancy or triplet. And here now you will have polyhydramnios. Polyhydramnios increase liquor is a risk factor for placenta abruption. And please remember also three important risk factor A, P, A whenever they are given in the examination. These are three risk factor for placental abruption. A for abdominal trauma. Whenever they have given abdominal trauma or any kind of trauma, think of placental abruption. P is for preeclampsia. Preeclampsia. And A for APLA. I have already explained APLA in detail. Okay. So these are the risk factors. Now, what are the other risk factors? History of previous LSCS. History of previous LSCS. History of previous LSCS is a risk factor for placenta previa. Okay. Or history of placenta previa is also a risk factor. Similarly, history of abruptio placenta. So these are the risk factor for abruptio placenta. These are risk factor for placenta previa. These three are common. And please remember this: APPA, abdominal trauma, preeclampsia, and APLA. Okay. So once you have understand this, now we'll come to the what are the sign and symptom and examination finding. Let me just what are the sign, symptom, examination finding, and management of the placenta previa. Now, in placenta previa, what is the most common complaint? It is a dictum that patient will come with painless and causeless fresh vaginal bleed. Patient will come with causeless, and why it is causeless? Because patient will say that I was just sitting and I started seeing vaginal bleed. So there will be a painless and causeless. So what will happen? There will be a painless and causeless vaginal bleeding. Painless and causeless vaginal bleeding. And this why it is called causeless? Because and this bleeding will be fresh bleeding. This will be a fresh bleeding. Now, if I'll compare this with the placenta abruptia, what will happen? The bleeding will be painful and it will not be causeless. There can be trauma or some preceding. So there will be a painful bleeding. There is painful bleeding. And the bleeding is generally dark color. It is not a fresh bleed. Dark colored blood. Okay. So this is the what symptoms patient will comes to you. Now what on examination, you will do the examination. Here, the uterus will be relaxed. Uterus will be relaxed. Uterus will be relaxed. Decreased tone. Okay. What happened now? What happened to the fundal height? Now, fundal height will be equal to period of gestation, and fetal heart rate will be normal. No fetal distress. No fetal distress. No fetal distress. Clear? Now, what will happen here? Here, increased tone of uterus. Uterus is not. Now, fundal height will be more than period of gestation in case of concealed abruption placenta. Why? Because in concealed abruption placenta, blood will be behind the placenta, so there will be increase in the size of the uterus. So the fundus height will be more, whereas fundus height will be equal to period of gestation in case of revealed. Okay, and there will be fetal distress. There will be fetal. Am I visible? Yes. So there will be fetal distress, or we can say fetal bradycardia. Fetal bradycardia will be present. Now, in placenta previa, what you will get on vaginal examination? What you will get in vaginal examination in placenta previa? Can anybody tell me? Oh my God, there are so many questions. Let me finish it first because already there is 5 o'clock. So, vaginal examination is contraindicated in placenta previa. Is contraindicated in placenta previa. So, vaginal examination you never do in placenta previa. This is a very important finding. How you diagnose? You diagnose through TVS. You confirm the diagnosis through TVS. Vaginal examination is not done. In abruptia placenta, I'm writing here in abruptia placenta because in the lower side my picture coming. So in abruptia, you will do a TVS. You will do a TVS. Why? To rule out placenta previa. To rule out placenta previa. And then if it is not placenta previa, diagnosis of abruptia placenta. Please remember, abruptia placenta is a clinical diagnosis. It is a clinical diagnosis. If there is a question and they ask, then placenta abruptia is a clinical diagnosis. So you have to remember on examination what you are finding, because this will help you in solving of the MCQ about the uterus tone, fundus height, and FHR, fetal heart. So these are the. Now coming to the how will you treat? Now treatment part, first we will take over the placenta previa. In placenta previa, there can be two. See, always remember one important point. In placenta previa, if you have to treat the treatment point, if you have to do this, if you have to either follow a expectant management or you have to follow a surgery. There is no other management in placenta previa. So in placenta previa, you can go for the expectant management. Yes, you can go for expectant management. But if you cannot go for the expectant management, the only thing that is you will go for the LSCS, that is cesarean delivery. There is no other medical management or there is no vaginal delivery. Okay? So no vaginal delivery. Please remember here, no vaginal delivery. No vaginal delivery. Either you go for the expectant management, and if you cannot go for the expectant management, you have to go for the cesarean section. Now, expectant management is basically called as a McAfee regime. McAfee regime. McAfee regime. This you have to remember. This is called as McAfee regime. When if the period of gestation is less than 37 weeks, if mother is stable, stable here means hemodynamic, hemodynamic stable, that is there is no tachycardia, no low, and no continuous bleeding. Please remember this term. No continuous bleed. Small bleeding, spotting can be present. Then about fetus, if the fetus, there is no fetus distress, no fetal distress, no IUD. In these cases, you will follow the expectant management. Okay, but if these things are not present, you will go for the simple cesarean CS, that is C-section. When if the period of gestation is equal to or itna 37 week, if mother is unstable or if there is a continuous bleed, if fetus there is fetal distress or if there is a IUD. So please remember this. In these cases, you will go for the cesarean section. Very important. Now, what about the abruptia placenta? Now, abruptia placenta, you can go for the vaginal delivery. Please remember. This is a myth that in abruptia placenta, you cannot go for the vaginal. You can go for the augmentation of the labor and you can go for the normal vaginal delivery. Normal vaginal delivery. Augmentation of labor is done through ARM, oxytocin. Okay, or membrane rupture, or by membrane rupture. ठीक है, medically you can go for the oxytocin. So I am doing a different color. Placenta abruption. Placenta abruption. What is, you will go for the, you will do augmentation of labor, and then vaginal bleeding. But if there is a fetal distress, what you will do? You will go for C-section, cesarean section. Now, very important point that abruptia placenta is a cause of DIC, if disseminated intravascular coagulation. If I ask you which is the most common cause of DIC, it is sepsis. Most common cause of DIC is sepsis, but most common cause of DIC in pregnant women, that is abruptia placenta, and that is evident if there is an increase of DPT. So if there, you can go for augmentation of labor and vaginal bleed. If there is fetal distress, go for the cesarean section. If there is also DIC, can you go for cesarean section? No, because if in a DIC patient you will cut the abdomen, patient will bleed and patient will be lost. So first what you will do, you will give FFP or prothrombin concentrate, and after that you will do augmentation of labor and vaginal delivery. Very important. So abruptio placenta, very important. Normal case, augmentation of the labor, vaginal bleeding. If fetal distress, cesarean section. DIC cannot go for cesarean section. First do FFP and or prothrombin. FFP is better, and then augmentation of labor and vaginal delivery. Okay. So these things. So I have APH. I have given you the short tricks. Now you can solve every question. Okay. Now let's start the questions. This Hypertensive pregnant woman at 34 weeks comes with a complaint of continuous pain, bleeding per vaginal, and loss of fetal movement past 1 hour. The uterus corresponds to the period of gestation, uterine contraction, and there is increased tone. Fetal heart sound is absent. What is the diagnosis? Now, please remember, very importantly, fetal heart sound is absent. यानी fetal distress में है या fetus death हो चुकी है. Increase uterine tone. This is second very important thing. So in placenta previa, uterine tone, we know that the uterine tone is not increased. So it cannot be a placenta. Can it be a placenta previa? No, it cannot be a placenta previa. Okay. Also, in generally placenta previa, fetal heart is can be listened. Okay. So it is what? It is a placenta abruption. It is a placenta abruption. Because if there would have been preterm labor, you will hear the fetal heart sound. Why it will be absent? And there is no need of hydrogen. So this is placenta abruption. This is very important. So this is how you have to solve the question. You have to know the examination fund just by knowing the uterine tone, that in placenta previa uterine tone is normal and it is increased in placenta abruptio. You have solved this question. Now second, hypertensive woman at 34 weeks comes with a complaint of continuous pain abdomen, bleeding per vagina and loss of fetal movement. On examination, the uterus correspond to the period of the uterus दोनों correspond कर रहा है. Uterine contractions are present, fetal heart sound is absent. Her pulse rate is 90 and BP is normal. That is means lady for now is stable. There is no prior ultrasound available. What is the next step? Do a PV examination, send for urgent immediate. Right? Simple. See, patient is stable, so you don't need to resuscitate patient now. So first thing is that you will send for an urgent ultrasound to know whether it is placenta previa or abruptio placenta, because initial and there is, see, they have written that on examination the uterine contraction present has, there is no prior ultrasound. So it is a very practical question that you will go for an ultrasound and try to know whether it is abruptio placenta, placenta previa, what is this. Okay. So you cannot do PV examination because in placenta you don't know it is placenta previa, because in placenta previa you cannot do a PV examination. Immediate cesarean section, you cannot do an immediate cesarean section of a lady without TV, without transvaginal sonography, without investigation. Admit in LR and induction of LR. How can you do this? If by chance it comes out to be placenta previa, then you cannot go for a normal vaginal delivery. So this is also false. So the only option by ruling out you can also is send for an ultrasound. Second, just by practically you should know that you should get an ultrasound done. Now, a 30-year-old G3P2L2 with prior vaginal deliveries, that means 2 vaginal deliveries, in emergency at 36 weeks with BP raised and is of abdominal pain for last 1 hour. Examination reveals a term size uterus which is tense and tender with mild contraction. Fetal heart rate is normal. Emergency ultrasound reveals a posterior fundal placenta with no retroplacental clot. That means it is not a placenta previa. PV is done. Now they are doing PV because they have known that it is not a placenta previa. This shows that cervix is 3 cm dilate, 80% FX, and fetal head is at -2 station with altered dark color. That means it is abruptia. This dark color bleeding has told you abruptia. There is what uterus is tense and uterus is tender. This is also telling that it is abruptia. So what you will do? Fetal is normal. Simply you will go for the augmentation and delivery. Okay. So admit involved, send blood indication and observe. There is no need for observing. There is no need of tocolysis. Admit in large, send blood and do ARN. सही है. Now admit in labor room and start oxytocin. But this can be also true, but you have to send blood investigation because this may go into PPH. So you should know what is the blood group of the patient, what is the KFT, LFT, how much blood I have to arrange, what is the hemoglobin. So you have to send the blood group. So answer will be C. So this is abruptia placent, and since the fetal heart, since there is no DIC and fetal is normal, there is no fetal distress, you will go for the vaginal delivery. So what you will do, you will send investigation, admit in labor room, send investigation, and do augmentation of labor. That is artificial rupture of membrane. This is artificial rupture of membrane. That is a thing for augmentation of the labor. Okay. So, because rupture of membrane leads to, we'll see, lead to the labor, starts the labor. Now, 27-year-old primary gravida at 34-week gestation present to the emergency department after a motor vehicle collision. I have told you collision, always remember collision. So there is a history of trauma. Her heart rate is 130, BP is 100. So it tachy, unstable. She is becoming unstable. And there is a history of abdominal trauma. Yes, all things are taking us to. She complains of severe abdominal pain. There is pain also. All things are taking us to abruption, which began immediately after the collision. Physical examination reveals bruising on the abdomen and with a hypertonic. Tone is increased. Also abruption. Altered dark colored vaginal bleed. Dark colored, that means abruption. Ultrasound confirms a fundal placenta with a large retroplacental hematoma. Emergency result shows an hemoglobin of itna. That means this is in DIC. So this is a case of abruptio placenta plus DIC. So will you do what you will do? You will first give FFP and then you will go for augmentation of labor. ठीक है, administer a tocolytic, ये emergency cesarean will lead to the death of the patient. So give her blood transfusion and FFP. And then after that, once INR and this you have resuscitated patient, you will go for the vaginal delivery. You will go for the vaginal delivery. This is very important. All are indication for termination of pregnancy in case of placenta previa. That means you have to understand McPhee regime. You have to. They are asking simply the McPhee regime. 37 week है. That means you have to go. IUD है. Yes. Transverse lie. Never I've seen. A significant bleeding. Yes. So answer is transverse lie. We have just seen McPhee regime and everything. A 32-year-old unbooked primary gravida came to the emergency department with vaginal bleeding at term. Her pulse rate is 90 per minute. BP is itna. That means lady is stable. Vaginal bleed हो रही है. APH है. On per abdomen examination, uterus is relaxed. That means high chances that it is a placenta previa. The fetus is cephalic in presentation, but the head is free floating. Fetal heart rate, ये भी fetus भी stable है. There is no active bleeding seen on the vaginal fluid. Active bleeding नहीं, all of the following is done. Except urgent ultrasound ये तो करोगे ही भाई. Send blood investigation करोगे ही. Clinical examination, immediate admission भी करोगे. So there is no need of clinical pelvic examination. कोई ये प्लेसेंटा प्रीविया है और आप देख रहे हैं कि जो मदर है वैजाइनल विद वैजाइनल ब्लीड के साथ आई है, तो आपको यार ब्लड इन्वेस्टिगेशन को भेजना ही पड़ेगा, अल्ट्रासाउंड करा के चेक करना पड़ेगा व्हाट इज इनसाइड एडमिशन, एंड फॉर ऑल दोस थिंग यू हैव टू एडमिट दिस पेशेंट बिकॉज शी मे लैंड अप एनीवेयर, बट देयर इज नो रोल क्लिनिकल पेल्विक एग्जामिनेशन है, so this will be the answer. A primary gravida 35 weeks of gestation reported to the labor room with central placenta previa, यानी complete है, and vaginal bleeding. Her pulse rate is इतना low, unstable हो गई है. On PA examination, the uterus is relaxed and fetus is in transverse line. The best. अब आपको पता है भैया, आप मैक्फी regime नहीं follow कर सकते यहाँ पर. आप और vaginal delivery placenta previa में होती नहीं, चाहे central हो चाहे कोई. तो आपको क्या करना पड़ेगा? You have to go for the cesarean section. So admit in ward and resuscitation in immediate cesarean section. Yes. Reduction and induction of labor. No, you cannot go for the resuscitation if she good falls. So answer will be B. B for Bombay will be the answer. Now, A primary gravida with 37 weeks of gestation reported to the LR with labor pain. Her vitals are stable, vital stable है. Examination shows that the uterus is term size and relaxed and the fetus is cephalic in presentation. She is getting mild uterine contraction. Ultrasound shows a healthy fetus and placenta is lying lower uterine segment. 1.5 centimeter. That means it is a grade 1 placenta. Grade 1 placenta previa. Fetus is stable. Oh, the best one. Now you are seeing fetus is stable. Don't there is no intrauterine death. Mother is stable. But once what you are seeing that it is 37 weeks. So you cannot follow Maxi regime. You have to go for the allow spontaneous rebel, no immediate cesarean section. Pervaginal examination is not done in placenta previa. Cesarean section if the woman bleed, no. So that's why I have asked you. You have to know what is Maxi regime. That slide was very important. Now, a 34-year-old primary gravida at 29 weeks of gestation present to the emergency department complaining of vaginal bleed for 2 hours. She soaked one pad. She has second trimester scan that show her placenta was in the lower segment. That means this lady is having placenta previa. BP is इतना hemoglobin इतना यानी stable. Lady is stable. Lady is stable. On per abdomen examination, the fundal height correspond to the period of gestation and the uterus is black. So it is placenta previa again. The fetus is breech and the itna heart rate itna. There is no active agent. What is the next management? What you will do? Now the lady is 29 weeks. Can you follow Maxi regime? So lady is stable. There is no is there continuous bleeding? Complaining of vaginal. There is complaining of vaginal bleeding. But she has soaked one, but just one show. I have told she has soaked one pad. One pad means around 50 to 100 ml. So I have told you while writing that there should be continuous bleeding. Now, and the fetus is also stable. There is no intrauterine breath. And very important is she is just 29 weeks. So what is best? Per vaginal examination you cannot do in placenta previa. Induction of labor you cannot do at 29. Emergency cesarean section and admit for observation, bed rest and steroid. Now you have to choose between A and D. At 29 weeks, if you know that you can follow Maxi regime in this patient because but you may be confused with this vaginal bleeding. One if in 2 hours just soaked one pad, that doesn't mean there is continuous bleeding. Okay, so you will admit for observation, you will give bed rest and steroid. Why steroid? Because 29 week lungs match for lung maturity, you have to give the steroid. So you will admit for observation, bed rest and steroid. But in case if there is a continuous bleed, BP start falling, fetal distress start, you will go for the emergency cesarean section. But not now, yeah. Here you have to admit for observation, bed rest and steroid. Now, a primary gravida at 37 weeks of gestation reported to the LR with central placenta previa and vaginal bleeding. Her vitals are stable. Per abdomen, they have already told it is a grade 4 placenta previa. Examination shows the uterus is term size and relaxed and the fetus is cephalic. Fetus is normal. There is no active vaginal bleeding. Active vaginal bleeding. Small amount on local examination. The best management is. But it is 37 weeks. So what you will do? Immediate cesarean section. Okay. One more question. A primary gravida has come for antenatal checkup at 20 weeks. Ultrasound at 18 weeks show placenta anterior in the lower uterine segment covering hose. No other risk factor. She is advised all. Report immediately. Episode of bleeding. Yes, you will schedule an ultrasound at 32 weeks. Yes, I will tell you why. Bed rest at home. Maintain adequate. What you have to tell her that you have to maintain adequate hydration. But there is no need for bed rest. So this is the option. This is the answer. Now why you will go for an ultrasound? Because there is something called as placental migration. Placental migration theory. There is something called as placental migration theory. There is something which is called as placental migration theory. What is placental migration theory? What is placental migration theory? So what happens if this is your placenta? Okay, and placenta, this is your sorry uterus, and placenta is here. So now, initially, now at 18 week, it is at the lower, at 18 week, it is at the lower segment. But when the uterus will grow, this will also grow, and this may, after 28th week, it may be here, placenta may come here. And now it will not be a placenta previa. Therefore, if you see a placenta previa at 18 week, you should also you should advise or you should schedule an ultrasound at 30 to 32 week, because I have also seen a lot of women in whose initial ultrasound they have a placenta previa, low lying placenta, but afterwards because of placental migration they are not a case of placenta previa. Okay, and they are normally delivered. Okay, so this is very important point. Now we'll come to the what is called as a postpartum bleeding. This is a very important point. Just give me 1 minute so that I take water for me. So postpartum bleeding. First thing that we have to understand in postpartum bleeding is when to call it a postpartum bleeding, what are the causes of postpartum bleeding, and how to diagnose. And mainly they ask question regarding the treatment. So if after delivery, how much blood loss you will call as PPH? You will call it as a PPH. So for that you have to remember, is it a vaginal delivery or it is a cesarean section? And in vaginal delivery, it is single or it is twins. If it is cesarean section or if it is twins, more than 1000 ml blood loss will be called as a PPH. In case of single delivery, more than 500 ml blood loss will be called as a PPH. This is very. Second definition is if the hematocrit loss is more than 10%. Okay, but you cannot wait in the OT or in the labor to look for that. No, we'll not call it PPH. We will not start the treatment until there is 500 ml of blood loss. So any bleeding, any bleeding which is abnormal, which is abnormal, which is abnormal, which is abnormal, or makes or makes the lady symptomatic. Which lady? Pregnant lady, not the anesthetist and surgeon. Which make the lady symptomatic, that is called as a PPH. Now, so this is what is called as PPH. What are the causes of PPH? There have always been 4T. One T is for trauma, other is for tissue, one is for thrombus, and is for tone. If I ask you generally, what is the most common cause of PPH? So answer will be atonic, loss of tone, that is atonic uterus. It is the most common cause. Most common cause of PPH is atonic. Thrombus means patient can have DIC, sepsis, or coagulopathy. Coagulopathy. Tissue is that is retained product of conception, that is placenta bits can be present. Now coming to the trauma. Trauma can be in the form of tears. For example, it can be cervical tear, it can be vaginal tear, or it can be perineal tear. We will study perineal tear in detail because a lot of questions is asked in perineal tear. Okay, so these can be trauma. Then there is very important uterine, then there is very important cause, that is uterine inversion. So I am highlighting this, I am changing the color. This perineal tear, this uterine inversion we have to study in detail. And third, we have to study in detail the atonic uterus. Okay, so first, now there are two questions which are asked that we will discuss here. What is the, it can also be classified into, where I should write here. PPH can also be divided into primary and secondary. Primary is that which happens within 24 hours. And secondary is after 24 hours. These are two. So I have told you what is the most common cause of PPH. What is the most common cause of PPH? The most common cause of PPH. Most common cause of PPH is atonic uterus. And if they ask what is the most common cause of PPH, what is the most common cause of PPH? Primary PPH. Then also your answer will be atonic uterus. Then your answer will also be atonic uterus. This is also the atonic. What is the common cause of secondary? So always remember RIP. R for retained placenta. Retained placenta. Is it visible what I am writing? Retained placenta. I is for infection and P is for placental polyp. In the same order. Okay, so primary, most common cause atonic uterus, although most common cause is also atonic, and secondary, more than 24 hours, remember the mnemonic RIP. So now we have to study perineal tear, uterine inversion and atonic. Okay, so first we'll understand how to manage atonic PPH. How to manage atonic PPH. First steps are the general steps. What you will do? Two wide bore cannula. It is called as 18 gauge cannula. You have to take, that is green. Okay, two wide bore cannula. Very important. Second, send investigation. Which investigation? First, so you will send for cross match because you need blood as soon as possible. Cross match plus order blood. Second, and before wide bore needle, please remember, call for help. Don't be a superman, call for help. send cross match, then send KFT, LFT, hemoglobin, PT, INR. हेलो, मैं तो लेक्चर कर रहा हूँ, ले रहा हूँ। तो ठीक है, तुम आ जाना, मैं उसमें क्या। अरे तो वहां से आ जाना, ठीक है। हाँ, so now we'll order KFT, KFT, LFT, PT and the INR. Okay, this cross match and send, sorry, I got my wife called. Two wide bore cannula, send these, and then third, call for help. Now, these are the general things you will do. And you will insert a Foley's catheter. Foley's catheter. Why you will insert a Foley's catheter? Because a lot of time, because the bladder is full, uterus is not able to contract properly. So that may be a cause of a atonic uterus. Secondly, after in the patient is in the PPH, when you will get fluid and blood, you have to keep the record of the urine. So that for that you have to have Foley's catheter. So these are the two reasons why you will put a Foley's catheter. After that, second, you will start uterotonics. Uterotonics. See, uterotonic, the first uterotonic is always oxytocin. It acts on the oxytocin receptor and causes contraction of the uterus to prevent PPH. So it can be used even for prevention, even for prophylaxis. In those cases where you feel that there can be very high PPH, you can use for the prophylaxis. So what is the dose? In normal vaginal delivery, you give 10 unit intramuscular after baby is out. In case of LSCS, you give 3 unit IV slowly, followed by 10 unit per hour. Now please remember, IV is not to be given more than 3 units and it should be given slowly because it can cause cardiac arrhythmias, even asystole or asystole. What are the other side effects? It can cause hypotension, it can cause tachycardia, it can cause long QT interval. These are the problems of oxytocin. Okay, so these are the side effects of the oxytocin. Now after oxytocin, what you can use? You can use prostaglandin. Secondly, you can use prostaglandin, carboprost, that is PGF2 alpha. What is the dose? Dose is 0.25 mg, which can be repeated every 15 minutes. Total 8 doses can be given. So you have given 0.25 mg. Total after 15 minutes you can repeat. Total 8 doses. So maximum what you can give? Maximum you can give 2 mg. Yes. It is contraindicated in asthma. Asthma means this is contraindicated. Prostaglandin has to be. So anesthetists generally ask in cesarean section before giving prostaglandin, or if they have taken the history previously, that are you a patient of asthma, because they have to give prostaglandin. And even it is a relative contraindication in URTI, upper respiratory tract infection. Okay. Now, what is the third? Third, you can give methargine. It is ergotamine. Methargine. What is the dose? The dose is 0.2 mg. 0.2 mg. Maximum dose you can is 5 dose in 24 hours. Okay, so maximum you can give is 1 mg. Maximum you can give is 1 mg. This you can give IV or IM. Please remember, prostaglandin is always given IM. If by chance you will give IV, that can cause cardiac arrest. Okay, prostaglandin is given. See, oxytocin can be given IV as well as IM. Methergine can be given IV as well as IM. But carboprost, prostaglandin is always given IM, never IV. Okay, this. What is the fourth drug that you can give? Fourth you can give, I will change the color. Fourth you can give misoprostol. Misoprostol. What is misoprostol? PGE1. PGE1. What is the dose? It is given 800 microgram. And what is the best way? Per rectally. Per rectally. Because woman is bleeding from the vagina. You cannot put it in the vagina. It will be washed. You cannot give orally because he or she may aspirate. So best is dose is 800 microgram per rectally, and it has no contraindication. It has no contraindication. Although it can cause diarrhea, because this can cause diarrhea, abdomen pain. This you have to understand. These are the 4 uterotonics that you have to use. So first was the general step, second was the uterotonic. Okay. Third, what will be the third step? Third step, you can use Bakri balloon. Bakri balloon. Or if you don't have Bakri balloon, you can use condom catheter. This Bakri balloon is around 7K, 8K. And you can also use Senjastikin black mare tube. It is actually used for esophageal varices. So Bakri balloon, what is Bakri balloon? For example, if this, now it depends how to insert it. If it is in cesarean section or it is in the normal vaginal delivery, you have to understand. Please remember, see, if I am doing cesarean section and the lady is in front of you, what will I will do? I have opened the uterus, so I will put the Bakri balloon in the uterus. It is like this. It has a balloon here and it has a two pipe like structure here. Okay, and then it is like this. This is the proximal part. I'm telling you, this is the distal part. Okay, so what I will do, I will put the this Bakri balloon, and what is the maximum uh, volume of this balloon? Maximum volume is 500 ml. This is the maximum volume. So what I will do, if the patient is undergoing cesarean section, I will put the balloon inside it, and then through the internal os, I will ask the other person in the OT, the nurse on the floor, to to wear the gloves and take out the other portion of the balloon. So other portion of the balloon will be out. So I will ask that to other portion of the balloon will be out, and then that portion of the balloon will be connected to a euro bag, and that person will instill water around 200 ml, 300 ml of water. So what will happen? It will create a tamponade effect. It will push the uterus. So the atonic uterus, the uterus was atonic, the uterus was bleeding. So that will be prevented. It will push, that is created tamponade effect. So this is how we insert it when inside the cesarean section. Okay. Now what is the Best point is that uh, now once you have filled it with the water, if there is any bleeding here, that bleeding can come out from the hair because it has two openings. So bleeding can be seen that even after because if you use condom catheter or if you use Sanjay's taken blackmail tube, you cannot know after putting it inside how much bleeding is there. But in if you are putting Bakri balloon, you can know how much bleeding is there because it has two ports. It has two ports. One for filling the balloon and other for and this is connected with the this other port is connected with the urobag. It is connected with the urobag. So you can see how much bleeding is there. So it is very good thing. Bakri balloon. What other thing you and preferably this Bakri balloon should be inserted in labor room or OT. This should be preferably in the OT. This has been asked as a question. Okay, so it should be always inserted into the OT because if there is other complication we can deal. Now how to insert it during vaginal bleeding? In vaginal bleeding you will simply insert through the vagina and if there is ultrasound you can check that it has moved to the uterus and then you will install water. So it's very easy. So you can insert it even in cesarean section and during the normal vaginal delivery. Okay. After this, what other thing that you can do? Then you can apply some sutures. These three sutures which can prevent. First is a vertical sutures. One is vertical sutures that you can apply. That is known as the link suture. Second is Heyman suture. Then third is Chose suture. So you have to just remember the name. B-link, Heyman and Chose sutures. These are the sutures. This is the fourth point. Now fifth point. Fifth point is you can go for sequential devascularization. Sequential devascularization. What is sequential devascularization? If this is your uterus, you can do devascularization of three arteries. You know, uterine artery is present here. Here it gives an ascending branch and a descending branch. So first you can ligate bilaterally this uterine artery. So first you will go for the bilateral ligation of uterine artery, followed or where you will do this, you will do it at the junction, at the isthmus junction, at the lower uterine segment, at the isthmus. Then you know we have an ovarian artery coming like here. So then you will go for close to the fundus here. Then you will do bilateral ligation of ovarian artery. You will do bilateral ligation of the ovarian artery. Then you also know that we have a common iliac artery that it gives external iliac artery. This is common iliac artery. This is external iliac artery and this is internal iliac artery. Internal iliac artery has two division, anterior division and posterior division. So from this bifurcation, 5 centimeter in the anterior division you have to ligate. So where you have to? So you have to ligate anterior division of the internal iliac artery. So what you will do? Bilateral ligation of anterior division of internal iliac artery. Please remember, if you ligate external iliac artery, the patient will develop limb gangrene. Patient will develop limb gangrene. The patient will develop the limb gangrene. Patient will develop limb gangrene. So this is very important. Okay, where to ligate? It is from 5 centimeter from the division. Internal iliac divides into anterior and a posterior division. So you have to ligate anterior division 5 centimeter from the bifurcation. So this is called as sequential devascularization. And the sixth point is finally hysterectomy. Hysterectomy. Finally, we have to go for the hysterectomy. These are the six. General management, uterotonics, then balloon, Beckley balloon, then sutures, then sequential devascularization, and finally devascularization. Now, very important, hysterectomy. Finally, very important, first and second point can be done in the labor or the OT, but for fourth, fifth, and sixth, that is suture, hysterectomy, sequential devascularization, that is these points, fourth, fifth, and sixth. You have to, this has to be done in the OT, sequential devasculation in the OT, and Bakri balloon is preferentially done in the OT. Has to be preferentially done in the OT. So if you have two options, Bakri balloon in OT, Bakri balloon in LR, what you will take? Bakri balloon in the OT. This keep in mind. So now atonic uterus you can manage very well. Everything is finished. Now very important, I have to told you about perineal tears. For example, bleeding because of the uh, perineal tear. So basically, you have to understand what is the, if this is the vagina, this is vagina, and this is rectum. This is the sphincter. These are the sphincters. Anal sphincters are of two types: external anal sphincters and internal anal sphincters. And then these are perineal muscles. Perineal muscles. So we have to know what is the, so we have to understand what is the grading of perineal tear. Because AIMS asks a lot of question on grading of perineal tear, and secondly it can ask question on the treatment, which grade when to treat. So in grade 1 there is injury to the vagina mucosa and the skin. So if there is grade 1 there is what? Vaginal mucosa and skin. So if there is tear in the vaginal mucosa and the tail. In grade 2 what happened? Grade 2 perineal muscles are also involved. In grade 2 perineal muscles are always involved. Especially there are two muscles which are involved. One is bulbospongiosus and second is superficial and deep transverse perineal muscles. Okay, these are two. And in grade 3, anal sphincters are involved. Anal sphincters are involved. Now, grade 3 is again divided into 3A, 3B, and 3C. If external anal sphincter is involved less than 50%, that is 3A. If external anal sphincter is involved more than 50%, that is 3B. If internal anal sphincter is involved, that is 3C. Now, if rectum is involved, that is fourth grade. That means you will put the hand in rectum and hand fingers will come out through the vaginal mucosa. So that will be a grade 4 perineal tear. Now, if you have now treatment, they ask you treatment time. Basically, they ask you treatment time. Now, there is also one thing that is known as episiotomy. Episiotomy. Episiotomy is actually grade 2 perineal tear. This has been asked. Episiotomy is grade 2 perineal tear. Now treatment time. If you have identified that the tear is tear within 24 hours, treat then and there, then and there, then and there. If after 24 hours, then best time is treat after 3 months. So there was a question asked in AIMS that a patient underwent a grade 3 perineal tear, and after 3 days she came with a bleeding and all those things and infection. So when to treat it? So now 24 hours has passed, so you will treat it after 3 months. Now grade, very important grade, we have 1, 2, 3 and 4. Okay. Grade 1 and 2 can be treated itself in the labor room, and grade 3 and 4 are treated in operation theatre. This is very important. So this is regarding the PPH about the perineal tear. Okay. There can be cervical tear, there can be vaginal tear. So that just in example, speculum examination, you can see vaginal tear, you can put packing, and if it is more, you can go for the sutures. Similarly for cervical tear, okay. And sometimes there are tears which you are not, there are tears, for example, there is a genital hematoma. So if they say that there is a swelling but bleeding is not coming, patient is undergoing an hypotension, that means there is a concealed hematoma. Okay, then what you have to do, you have to do incision and drainage. Now very important, in which a lot of question has been asked now, is related to the uterine inversion. Uterine inversion. So in MCQs of uterine inversion, you will always be telling that there was a normal vaginal delivery was going, which was being done by some intern or by some less skilled person. That is, I am not saying that interns are less skilled, but just for question purpose. Otherwise, interns are the most expert person in the hospital. Normal vaginal delivery is being done by the intern or by a less skilled person like guy. So what he has done, he baby has come out and this is the placenta, and we all know that there should be controlled cord traction. So instead of controlled cord traction, she has continuously pushed it. So this portion has come down. This portion has come down. This is no, that is fundus. Fundus came down. Fundus came down. So this is what is known as uterine inversion. Now very important point regarding this. In all the PPH, what you will see, BP falls and you see tachycardia. And you see tachycardia, fall of BP. But in uterine inversion, the peritoneum along with the vagus nerve is also stressed. So what happens? You get a neurogenic shock. Which kind of shock? You get a neurogenic shock. Neurogenic shock. Neurogenic shock, what you will see, there will be low BP and decreased heart rate. Low BP and low heart rate will be there. So this is a very important from other causes of PPH. There will be low BP, tachycardia, here BP will be low and less. So what? So initially, so there will be very, so in the question they will say very less vaginal bleed, very less vaginal bleed. Okay, so it is because of the neurogenic shock. It is true that this patient will finally go into the atonic uterus. Finally will go into the atonic uterus. So you will give uterotonic drugs. Uterotonic drugs. You will give uterotonic drugs, but not now. Okay, you will not give uterotonic drugs now. Initially, what you have to do management, because it has come, so you will just put your hand and try to reduce it. This is known as Johnson method. Johnson method. I don't have a picture. So this is known as a Johnson method. Second method is that you take a drip set and put, you start infusing saline and with your hand you try to reduce. So you are reducing with the help of your hand and also through the saline, that is hydrostatic pressure. So second is the hydrostatic method. Hydrostatic method. What is this method known as? This is known as O'Sullivan method. O'Sullivan method. So first is just with the help of hand you are trying to reduce. Second is hydrostatic method, or that is known as O'Sullivan's method. Third is the surgical method. So there are two surgeries which are done laparoscopically, laparotomically. One is Huntington, and second is Haltane. Haltane, H-A-U-L-T-A-I, Huntington, and these are surgical. So first is Johnson's, that is manual reduction. Second is O'Sullivan's, that is hydrostatic reduction. Third is surgery, that is Huntington's or Haltane. So this is regarding the uterine inversion. Always remember, there will be less low BP, low heart rate, that is neurogenic shock, followed by, so uterotonic will be given, but first you have to follow this method. Okay. So this was regarding the PPH. Now, abnormal uterine cavity and physiological change. Now, first we are left with some things like adenomyosis. What is adenomyosis, fibroid, and physiological change in pregnancy? These three mega chapters are left. So now let's start. Okay, it has been how many hours? So, and is there anyone in the Google? No one is in Google, but everyone has left. Okay, let's see. So now, first we have to understand what is a normal bleeding. What is a normal bleeding? So normal bleeding always is around 35 to 50 ml, and it is for 2 to 8 days, and it is for uh, 21 to 35 days. Cycle. This is cycle length. This is duration of bleeding, and this is amount of bleed. Okay, this is normal. If someone asks me what is normal bleeding, I'll say that 30 to 50 ml of bleed, 2 to 8 days, and 21 to 35. Now, if there is more than 8 days of bleeding and more than 80 ml of bleed, that is called as menorrhagia. Menorrhagia. That is called as menorrhagia. That is heavy menstrual bleeding. If the bleeding is for less than 2 days and less than 20 ml, that will be called as a hypomenorrhea. That will be called as hypomenorrhea. Okay. If the cycle length, if the cycle, if it is less than, if each cycle is coming before 21 days, or it comes after 35 days. So this is known as polymenorrhea. Sorry, Polymenorrhea. Polymenorrhea. Why polymenorrhea? That means in a year there are more number of cycles. That's why it is poly. People get confused that it is less than 21 days, then why it is called polymenorrhea? It is called polymenorrhea because the cycle is less than 21 days. Then more than 35 days, more than 35 days. If I ask more than 35 days, then it will be called as oligo, oligomenorrhea, oligomenorrhea, oligomenorrhea. Okay, this is very important. You have to know these things. So when a patient can comes to you, so any of patient can come with menorrhagia, patient can come with hypomenorrhea, patient can come with polymenorrhea, patient can come with the oligomenorrhea. Okay, but now today discussion of topic is what? It is fibroids and adenomyosis. Fibroid and adenomyosis. So in fibroid and adenomyosis, patient will come with menorrhagia, will come with the menorrhagia, basically menorrhagia. So first let's see what is abnormal uterine bleeding. Okay, what is abnormal uterine bleeding? When you will say whenever there is abnormal uterine bleeding, you have to understand something that is called as palm point. Okay, so this is the mnemonic. Please remember palm. What is the palm? Palm refers to the structural causes of abnormal. P is for polyp. A is for adenomyosis. L is for leiomyoma, that is called as fibroid. M is for malignancy. Okay, so these are structural forms. And this coin COEIN, this is for non-structural form. This is for non-structural form. C is for coagulopathy. O is for ovulatory dysfunction. We will study all those things. E is for endometriosis. Endometriosis. I is for idiopathic. N is for non-specified. So whenever there is question, you have to think in terms of this. But now today, let me change the color. The topic of discussion is basically adenomyosis and leiomyoma. Okay, adenomyosis and leiomyoma. So first we will go for what is leiomyoma. Leiomyoma, or simply we called it as a fibroid. So this is, first remember, it is a soft tissue tumor of uterus. It is a soft tissue tumor of uterus. Most common pelvic tumor of women. These are question. These all are question. It is estrogen dependent. Estrogen dependent. So more common in obese, nulliparous, and young women. This is about the leiomyoma, soft tissue tumor. Okay, common in now. It can be of different types. Please remember, if this is the uterus, this is the uterus. So it can be at the serosa. So this is serosal. It can be at the serosa. Secondly, it can be at the serosa and pedunculated. So it can be pedunculated. हाँ निहाल, क्लास ले रहा हूँ. हेलो, क्लास ले रहा हूँ, क्लास अभी तो है ही नहीं. वो दे देता हूँ आपको बना के, उसको दे दीजिए, उसी जब मिलेगा ले लीजिए. अभी तो सच में नहीं, मैं सड़क से दे देता. कितना 50 चाहिए ना, कुछ अपनी वाइफ से ले लेता हूँ. ठीक है, बस अभी आ रही है, मैं उससे बात कर लेता हूँ. बस में ही है, बस पहुंच ही रही है. मैं बताऊंगा. दिमाग से उतर गया, जमा कर देता. ठीक, कोई दिक्कत ही नहीं उसमें. ठीक. So that can be in the pedunculated serosa. Secondly, it can be intramural, that is in the myometrium. It can be intramural. Third, it can be in the mucosa, that can be submucosal. Now there is in submucosal, one can also have a pedunculated. This is pedunculated submucosal. This is also called as fibroid polyp. So this is very confusing. Fibroid, a lot of time in the Viva they ask fibroid polyp is a polyp or fibroid. So first naam starting is with the fibroid. So it is a so it is a also known as intracavitary fibroid. It is called as intracavitary fibroid. It is an intracavitary fibroid. Now there is a very important, that is pedunculated submucosal fibroid, also known as um, fibroid polyp or intracavitary. It has a very important symptom that it shows intermenstrual bleeding. So this question was asked in AIMS examination. AIMS examination. That which of the following polyps, and answer was intracavitary fibroid. This can also come all to the down to the os, and it can also cause post coitus bleeding. When the penis hits it, that can cause so it can cause intermenstrual bleeding and post coital bleeding. So this is regarding the types of the glioma. Okay. Now, how you diagnose glioma? The diagnosis of glioma is done with the help of the ultrasound. And what you see hypoechoic masses, hypoechoic masses, hypoechoic masses, hypoechoic masses. What is the treatment? How will you treat it? The basically treatment of fibroid is basically surgery. So you can go for the myomectomy, laparoscopic myomectomy, or you can go for open myomectomy. You can go for laparoscopic myomectomy or you can go open. There is very important point. I'll change the color. These fibroid polyp or intracavitary polyps, if 50 or the submucosal polyp, if 50% of the polyp is outside the mucosa, what I'm telling, if they are 50% outside the mucosa, do you can remove this fibroid through hysteroscope. So that will be called as hysteroscopic myomectomy. I'm again telling you what I'm telling you, that if this is the polyp, if this is the mucosa and this is the polyp, and this polyp if polyp is of 10 centimeter and 6 centimeter of the polyp is in the cavity of the uterus, then that means 50% of the polyp is outside the mucosa, has come into the cavity. Then you can plan what? You can very well plan the hysteroscopic myomectomy. So this has been asked. When you will do hysteroscopic, normally you do laparoscopic myomectomy. For example, if this is a serosa, this is pedunculated intramural, these you cannot remove through hysteroscope. You can remove only that fibroid with hysteroscope which has more than 50% has come inside the cavity. Okay, so this is the treatment part. And now very important is what is the symptoms and signs, because you have to know what is the symptom and the signs. Okay, so symptoms and signs. What are the symptoms and what are the signs of fibroid? So patient will present you with bleeding and painless. Pain will be absent. Painless. So patient will present you bleeding, pain will be absent. When you will do the examination, uterus will be enlarged. Uterus will be enlarged, but there will be asymmetrical enlargement. There will be asymmetrical enlargement. Uterus will be non-tender. It will not be tender. And uterus will be non-tender and it will be hard. What is known as bossulated appearance. Bossulated appearance. Okay. So this is what you see on examination. This is very important because a lot of time in question they give. So there will be bleeding, but bleeding will be painless, enlarged uterus, non-tender, hard. Now when we will read adenomyosis, we will compare and contrast with adenomyosis. Now, what is adenomyosis? Now, coming to the adenomyosis. Adenomyosis simply means if this is the myometrium. This is endometrial stroma and endometrial glands. If the endometrial stroma and glands are present, if there is a streak or a breach in the endometrium, these endometrial stroma and glands can be also seen in the myometrium. So this is what is known as the adenomyosis. So adenomyosis is basically presence of endometrial glands and stroma in myometrium. In myometry. So presence of endometrial glands and stroma in myometrium is known as adenomyosis. This is very important point. Okay, this is what is called as adenomyosis. Adenomyosis is generally a painful and a very tender thing. So what is the symptoms? What is the sign? Now compare and contrast with the fibroid. In fibroid, the patient was having pain was absent and there was bleeding. Here it will be very painful and there will be bleeding. Secondly, fibroid, there was asymmetrical enlargement. And here the enlargement will be symmetrical enlargement. Symmetrical enlargement. Okay. It will be tender. This is non-tender. Okay. This was adenomyosis uterus will be soft. This will be the hard. Okay. And this is called as bossylated. So this you have to understand. Oh, sorry, I think I am not. What I am writing, is it visible? Okay. So this is how to differentiate between adenomyosis and adenomyosis. Now, what is the investigation of choice for adenomyosis? If they ask you best investigation for adenomyosis, it is the MRI. Best investigation, it is the MRI. But investigation of choice or the initial investigation, it is TVS, transvaginal sonography. What you will find, for example, if this is the uterus, this is the anterior part, this is the TVS, we are doing TVS, this is the anterior part, this is the posterior part. Okay, so this is myometry. This is myometry. So what happened in this? You will see myometrial glands, myometrial cysts, myometrial cysts. What you will see? You will see myometrial cysts. And if I ask you which is the most specific finding, this is the most specific finding, most specific findings. Secondly, what you will see? See, this is endometrium and this is myometrium. So there is a junction. So this junction gets obscured. So endometrial and myometrial junction get obscure. Endometrial and myometrial junction get obscure. This is one thing. So most specific is myometrial thickness. Second is endometrial myometrial junction get. Secondly, you can see hyperechoic lines like this. That is white line. Hyperechoic line like this. Hyperechoic lines like this. What are these lines? These lines, this is known as Venetian Venetian band sign. So this hyperechoic lines. These are because of the I've told you that there is a streaks in the endometrium. So these are hyperechoic line, also known as Venetian band sign. Okay, endomet. So these three things you see in this. Very important thing. There is myometrium, increased thickness of myometrium, increase thickness of myometrium. Please remember, posterior thickness increases more than the anterior thickness. Okay, this is a very specific to adenomyosis. The thickness, posterior thickness is more than the so myometrial cyst. Presence of myometrial cyst, endometrial myometrial junction get obscured, hyperechoic line, that is Venetian band sign, and thickness of. Now, what you see in MRI. Please remember, MRI you calculate something that is called as junctional zone. Junctional zone. And if the junctional zone is more than 12 millimeter, that is a confirmed diagnosis of adenomyosis. If it is less than 8 millimeter, then it is not adenomyosis, not adenomyosis. It is not adenomyosis. And between 8 to 12, it is equivocal. We see sign and symptom. This is very important. Adenomyosis. Okay. So this is how you do. What is the treatment in adenomyosis? The treatment of adenomyosis is always and always hysterectomy. Hysterectomy. Treatment of adenomyosis is hysterectomy. Okay. So this was related to adenomyosis, fibroid. Now we'll come to the last part, that is physiological changes in pregnancies. What are the physiological changes in pregnancy? What are the physiological changes in pregnancy? So see, what are the physiological changes in pregnancy? Changes in pregnancy. First, we will see the metabolic and endocrine changes. Metabolic and endocrine changes. So, in endocrine changes, we have to remember which are the hormones that increases, which are the hormones which decreases. Now, what happens is that in case of uh, pregnancy, there is increased beta HCG, and beta HCG is equal to TSH in function. So what it does, beta HCG increase T3 and T4 production. Okay. For example, initially there were 5 T3 and 5 T4 molecules were made. So now there will be 7 T3 and 7 T4 molecules made. Now there is liver is also making thyroid binding globulin. It is making thyroid binding globulin. That is also increasing. Now, so we all know that thyroid hormones, this is slightly tricky. Thyroid hormones exist in two forms. One is the free form and other is the bound form. Bound, that means thyroid binding globulin. Now, so this is free T3, T4. So initially it was 5, now it comes to 5. Now this 2 increase, this 2 T3 increase in the T3 and this 2 increase T3 bind to the thyroid globulin binding globulin, because thyroid binding globulin is also increase in protein. So what happened? Free T3 T4 remains 5. So there is no change in the free T3 T4. I'll change the color. So there what happened? It remains 5 because the 2 T3 and T4 that was increased has bounded to the thyroid binding globulin. So bound now, so free form, so free form it remains same, but the bound form has increased. That has increased. This is very important point. Now, what has happened to the TSH? TSH remains normal because it is the beta SCG which is behaving like the TSH. Okay. So if we talk that, and what will happen to the total T3, T4? Total T3, T4 will increase because bound has increased. So free form remains same. Bound form increases because thyroid binding globulin increases and total T3, T4 increases and TSH remains normal. But please remember, if someone asks you in very detail, there is a slight reduction of TSH in second trimester. But then in first trimester, then in second and third, it remains same. So we take TSH to be that its value doesn't change. There is a slight dip in the first trimester. Okay, so this you have to understand, that very important. So whenever you will order thyroid in a pregnant woman, you will always order free T3, T4 because bound and total will increase. So always order free T3 and free T4. This is the first thing that I wanted to keep in pregnancy. Now we have to understand what are the hormones which increases and what are the hormones which decreases. So please remember, the hormones which increases in pregnancy, you can remember them by the norm pat gai. I for insulin, G for growth hormone, T is for testosterone, P is for prolactin, and A is for aldosterone. Because we know that RAS is activated in pregnancy. RAS. Now, very important point regarding insulin. What is the hormone? Unchanged. TSH, ADH, that is also called as vasopressin, and free T3, T4. These are unchanged. And what are the hormones which are decreased? That is LH, FSH. Regarding very important point that has been asked is progesterone and estrogen. Initially, 2 months they are secreted by the corpus luteum. They are secreted by corpus luteum. Placenta, when they start secreting from the placenta, 7th week estrogen and 8th week progesterone. This has been asked. So initial 2 months progesterone and estrogen are secreted by the corpus luteum, and from the 7th week it is the estrogen and 8th week it is the progesterone. Now, very important thing that I wanted to tell you about insulin. See, insulin increases, so but also insulin resistance increases. So what happened to the glucose? Glucose increases. Why this glucose increases? Because this increased glucose can be used by fetus. That is why insulin increases, but insulin resistance also. Now they ask you, what are the hormones which increases insulin resistance? So there is increase in the insulin, but there is increase in insulin resistance, and glucose increases, which can be used by the baby. So these are four hormones that you have to understand. One is progesterone, other is estrogen, third is HPL, human placental lactogen, and fourth is cortisol. They have asked that which of the following hormone does not play a role in increasing insulin resistance, and answer was prolactin. Although prolactin increases, but it does not play a role in maintenance of the insulin resistance. Now, very important point regarding prolactin. Prolactin increases. Now, see here. This is prolactin. This is pregnancy. This is the place where the baby is delivered. So, prolactin increases like this, and after delivery, the prolactin decreases. So, at term, prolactin is maximum at the term. Now comes the question. Very important question. We all know that prolactin is for formation of the milk. Prolactin has to form the milk. Then why it should be more after the delivery? But no, it is not so. Now during the delivery it increases, and at that term, but there is no milk formation because its effect of formation of milk is counteracted by the progesterone and the estrogen. So because of the progesterone and estrogen, it is not able to form the milk. But after the delivery, the progesterone and estrogen falls, so even the low amount of prolactin can form the milk. So there are two questions. Prolactin is maximum during the time of term, but why milk is not formed? Because its action is prevented by the estrogen progesterone. And why it forms after the delivery even at low level? Because progesterone and estrogen is less. This is very important point. Okay. So this was regarding the hormone. They can ask you these questions. Now coming to the metabolic part, what happened to the protein, cholesterol and all those things? So if I talk of proteins, albumin decreases, globulin increases, all amino acid without any exception increases. This is regarding protein. What happened to the lipid? Triglyceride, LDL, HDL and cholesterol all increases. Very important. All increase. This was regarding protein, lipids. Okay. Carbohydrate always explained that there is insulin resistance and everything I have told you. This is regarding metabolic and now coming to the renal changes. What happened to the renal changes? Renal changes can be grouped under two. One is the morphological changes and other is the uh, chemical changes. Now please remember that renal blood flow increases, creatine clearance increases. So when renal blood flow and creatine clearance increases, so all the waste product decreases. Serum creatine decreases, blood urea nitrogen decreases, uric acid decreases, serum potassium, calcium, magnesium, sodium, iodine all decreases. So this you have to keep in mind. Okay. The renal blood flow and creatine clearance increases. Okay. What is the renal blood flow? It is around 400 ml per minute. 400 ml. Morphological, renal size increases. Renal size increases by 1.5 centimeter. Okay, but corticomedullary junction remains same. Now please remember, if this is the kidney, this is the ureter, bladder, so there is increased urine in the ureter. So you see that is you see uretrosis. You also see increase congestion in ureter, increase congestion in the kidney, hydronephrosis, So you see hydroureteronephrosis, mainly on the right side. Why mainly on the right side and not on the left side? Because generally there is dextrorotation of the uh, uterus. Because on the left side we have sigmoid colon and descent sigmoid colon and all those things. So uterus generally, in large uterus generally moves to the right side. Therefore, there is more there is more uh, urinary congestion in the right sided. So hydroureteronephrosis can be present on both sides, but mainly present on the right side. Then bladder volume decreases. So there is increased frequency of micturition, increased frequency of micturition. Okay. Also, bladder pressure increases. Bladder pressure increases. Volume decreases, so pressure increases. Also in urethra pressure increases. So morphologically renal size increases. There is hydroureteronephrosis on the right side more than the left side. Bladder volume decreases. Bladder volume increases. So micturition increases. Also urethral pressure increases. So these are the renal changes that you should know. Okay. After the renal changes, we are left with the uh, pulmonary changes. Okay. Or first we see hematological changes. Hematological changes. What happened to the RBC number, RBC size, RBC mass, hemoglobin mass? Please remember they all increases. RBC number slight increase. But since we know that there is increased blood volume, why I tell you in the cardiac part, increased blood volume. The hemoglobin concentration, when we talk in terms of gram per dl, it decreases. Therefore, we get an anemia that is known as physiological anemia. That is called as physiological anemia. If there is less than 11 hemoglobin in first and third trimester, that is anemia. Less than 10.5 hemoglobin in second trimester, that is anemia. Remember this. Less than 11 hemoglobin in the visible, less than 11, less than 11. Okay. Now, what happened to the platelet? What happened to the platelet? Platelet decreases. What happened to the leukocytes? Leukocytes increases. Okay. INR and PT, APTT normal. All clotting factors increases except 11 and 30. Okay. Anticoagulants like protein C and S decreases. So that means pregnancy is a procoagulant state. Pregnancy is a procoagulant state because there is high chances of clot formation. Okay, in pregnancy. That's why you can see DVT, pulmonary embolism in pregnancy. Okay. So why they ask? Because all the clotting factor increase except 11, 13 and anticoagulant like protein CNS decreases. So these are related to the hematological changes that can be asked to. Okay. Now, what is the cardiac changes? Cardiac changes. Cardiac. What are the cardiac changes? Okay. We all know that blood pressure is cardiac output into peripheral resistance. P for peripheral resistance is P for progesterone. So we know that progesterone increases. Okay. So peripheral resistance decreases. There is decrease in the peripheral resistance. Cardiac output is actually stroke volume into heart rate. they both decreases. But since cardiac output is increasing and peripheral resistance is decreasing, the net effect on BP is that BP is reducing. Diastolic blood pressure reduction is more than the systolic blood pressure reduction. This is very important. Diastolic blood pressure reduction is more than the systolic blood pressure reduction. So this is what you have to understand. Now, very important point regarding cardiac output. Cardiac output start increasing from the 5th week. Then it increases till 32 week. Then it slightly increases during labor. Then it is maximum after delivery till 1 hour. Okay, so pre-labor cardiac output, remember 2 points. Cardiac output reaches to the pre-labor status 1 hour after the delivery, and it reaches to the pregnancy level after 4 to 6 weeks. Okay, so cardiac output reaches to the preterm level after 1 hour. Okay, so what I say that if I say cardiac output, if I say descending, if I put it in descending order, so from maximum to minimum, so it is maximum at 1 hour after delivery, then second stage of labor, that is during labor, then 32 weeks. So when the cardiac output is maximum, there the chances of heart failure is maximum. So heart failure chances is maximum. Heart failure chances is maximum during the time 1 hour period from the delivery. Then in labor during the second stage of the labor. Then at 32 weeks. What is peripartum cardiomyopathy? It is the dilated cardiomyopathy from, if this is the delivery, so 1 month back and 5 months after delivery. So if there is a dilated cardiomyopathy 5 months after the delivery or 1 month before the delivery, during this 6 month period, that is called as peripartum cardiomyopathy. And my friend, there is no treatment of peripartum cardiomyopathy. So these are the things which you have to understand regarding cardiac changes, heart rate, and everything. Okay. Now, second point is what are the ECG changes? That is, what are the ECG changes? So, what are the normal ECG changes? ECG changes. So, normal we can get a left axis deviation, very important. You can get STT changes in V3 to V6. What are STT changes? That is, you can get ST depression and T wave inversion. Okay. Then you can get Q waves in AVS. Now, what is a normal Q wave? We should know what is a normal Q wave. What is a normal Q wave? Normal Q wave is found in lead V5, V6, lead 1 and AVL. But if the, and what is the width? Width should be less than one small box and depth should be more than should be less than two small box. So this is what is called as a normal Q wave. Okay, but large Q wave can be seen in AVF, which is normal in pregnancy, This you have to understand. Now coming to the third point, STT, you will get sinus tachycardia. That is normal. Most of the lady you will have sinus tachycardia. And please remember, you can get QTC, that is QTC, corrected QT segment elongation. Normal QTC, normal QTC in male is, and what is in female? It is less than 460 in female and it is less than 440 in male. If it is more than 440 in male, it is called as a long QT syndrome. If it is more than 460 in female, that is called as a long QT syndrome in females. And if it is more than 500, irrespective of the female, male and female, then it can have high chances of development of torsades de pontis. Tarsos de pontis. What are the drugs which can cause long QT interval? Very important in pregnancy, you should know. Thiazide. Thiazide, very important. Then opioids, which are used by the anesthetists. Then ondansetron. Ondansetron can cause. Then quinidine. Then all antipsychotics and antidepressant. Then risperidone especially. Then you have like these macrolides. Okay, these are the drugs which you should know, and very important, oxytocin. These are the drugs that can cause very high QT interval. So these you have to avoid if there is increased QTs. This was the ECG changes. Okay, what is the echo finding that you can see? A lot of people get. So in echo, we can get eccentric hypertrophy. Eccentric hypertrophy. Now there are two kinds of hypertrophy. What is eccentric and concentric? This will also help you in cardiology. If this is your myometria, if this is your myocytes, this is your myocytes. Now I am talking of heart, and if it grows like this is the heart, and if it grows like this, so initially myometrium thickness was this. Now see the thickness has increased. Now this is the orifice area. So now inside the cavity, volume has decreased or increased. Volume has decreased. So pressure will be increased. So this situation will be known as pressure overload. And this kind of hypertrophy is known as concentric hypertrophy. Concentric hypertrophy. This is known as concentric hypertrophy. This is seen in two special conditions, aortic stenosis and hypertension. So whenever in echo you see concentric hypertrophy, be clear that it is always pathological. Always pathological. So concentric hypertrophy will always be pathological. Always pathological. Now let's see what happened in case of eccentric hypertrophy. Eccentric hypertrophy is like this. There is increase in the length. So what happened? Volume increases. So pressure decreases. So there is hypertrophy, but there is no pressure overload. So there is what is increasing. This is called as volume overload. This is called as volume overload because volume is increasing. So this is seen in cases of people doing exercise or in cases of pregnancy, athletes. So whenever you see eccentric hypertrophy, for example, if a person is coming to you that I do a lot of exercise, there is hypertrophy, and he shows his echo report and it shows concentric hypertrophy, then tell him, no, Babu, it's not good. It is concentric hypertrophy. It is pathological. If it would have been because of your exercise, it would have been what? It would have been eccentric. It would have been eccentric hypertrophy. It would have been eccentric hypertrophy. if it would have been because of the volume overload. So in pregnancy, what you see? You see eccentric hypertrophy. In exercise, you see eccentric, this kind, and that is basically a volume overload. And in pressure overload, you see a concentric hypertrophy. That is very important point. Okay, so hypertension, aortic stenosis, concentric, exercise, athlete, pregnancy, eccentric. If in pregnancy you see concentric, that is pathological. Carry home message. Okay, on X-ray, what you see? You see cardiomegaly. On X-ray, you see cardiomegaly. So these are the cardiac changes. Now we are left with the respiratory changes, and today class will be finished. You will be, but if you will take these 5 classes of mine, you will be expert in obs and gynae. Okay. So pulmo changes. What are the pulmo changes? We know that this is diaphragm. Okay. So diaphragm moves up. So diaphragm moves up by 4 centimeters. This has been asked in question. Now there is AP diameter. There is transverse diameter. AP diameter increases by how much? It increases by 2 centimeters. Transverse diameter also increases by 2. Circumference increases by 5 to 7 centimeters. So diaphragm moves up by 4 centimeters. AP diameter moves increase by 2 centimeters. Transverse diameter moves by 2 centimeters, and circumference increases by 2 centimeters. Now basic is how to remember which value, capacity increases, which volume increases, decreases. So first understand, we have been from time immemorials reading this, that we have IRV, then this is IRV, then this is TV, then this is ERV, then this is RV, this is IC, this is FRC, this this complete is vital capacity, and this complete is total lung capacity. How to remember which is increasing, which is? So please remember, in Hindi there is a shabd which is named as veer. Veer people are very veer, very strong. They never change. So if you write veer, VIR, so veer people will never change. So what is Y? So these are those volumes or capacity which will not change. So what is V? Y is for vital capacity. I is for inspiratory. Now you can have confusion that inspiratory capacity or volume. So what is written? R. So it is inspiratory reserve volume, and R is for respiratory rate. So these are the things which does not change. I'll change the color. Okay. So V does not change. Now which increases? Which increases? So always remember TIM. T is for tidal volume, increases. I is for inspiratory capacity. M is for minute ventilation. And next M is for minute oxygen requirement by cell. So this is TIM. Now which decreases? Now you can very easily see which decreases. Now what happened to the IRV? We have seen that IR, inspiratory reserve volume, does not change. So it is unchanged, does not change. Unchanged you see. Then what happens to the tidal volume? The tidal volume increases. So tidal volume increases. What happened to the ERV, expiratory reserve volume? That means it is not, it will decrease. What happened to the reserve volume? There is nothing reserve volume, so this will decrease. If ERV and RV are decreasing, what will happen to the FRC? It will decrease. What happened to IC? It is there, IC is increased, so IC will increase. What happened to the vital capacity? Unchanged. So that is unchanged. So this is how we have to remember. TLC can have different, can be normal, can be abnormal, can be decrease or increase. So this is how you remember everything. First remember from V that they does not change. Then from TIM remember uh, increasing, tidal volume increases. So from this you remember increasing. Then what are left are decrease. And you can solve questions regarding it. So this was the, out of the 5 classes, this was the first classes of obs and gynae. 4 are more left. If you will take those 4 classes, you will be expert in the practical aspect as well as solving MCQ. Thank you very much. बहुत ही जल्दी मिलेंगे.